يحتوي الملتقى على جلسات علمية ستكون في هذه القاعة الرئيسية، وتضم 14 جلسة علمية إضافة إلى 5 ورش عمل متخصصة سيتم إقامتها في اليوم الأول في قاعة مركز الأطراف الصناعية والجبائر في المبنى الشرقي المجاور، وفي اليوم الثاني ستكون في قاعة مركز إيفاء للتدريب في الدور الأول من هذا المبنى، علما بأن الساعات العلمية في هذا الملتقى معتمدة من الهيئة السعودية للتخصصات الصحية، إضافة إلى وجود معرض مصاحب للملتقى في منطقة التشريفات في القاعة في منطقة التشريفات الرئيسية. في المدخل الرئيسي لمجمع الأمير سلطان للتأهيل ستجدون الأماكن المخصصة للتسجيل في ورش العمل، وسيتم عرض جداول الجلسات العلمية وورش العمل في موقع الملتقى وعلى الشاشات واللافتات الداخلية وفي حسابات التواصل الاجتماعي. وننوه إلى أهمية الحفاظ على هدوء الأجواء أثناء الجلسات العلمية في الملتقى، وذلك من خلال ضبط الجوالات على الوضع الصامت. ونتشرف بضيافتكم خلال الفواصل التي ستكون بين الجلسات المخصصة للراحة، وذلك في منطقتين، الأولى في منطقة المعرض يمين البوابة الرئيسية، والثانية في منطقة التشريفات يسار البوابة الرئيسية. بالنسبة للنساء ستكون دورات المياه والمصلى على يسار المسرح، وستكون دورات المياه للرجال عند مدخل هذه القاعة والمصلى في الممر المقابل لها. وفي حال احتياج أي مساعدة ستجدون اللجان التنظيمية المتخصصة في هذا الملتقى في خدمتكم دائما. أجدد الترحيب بكم حضورنا الكريم، وننتقل الآن إلى أولى الجلسات العلمية لهذا الملتقى مع الدكتورة أمل طناب، فلتتفضل مشكورة.
Thank you for the introduction. I will start my topic today for the first day, which will be about spotlight of standards of care for persons with limb amputation. This is my disclosure. So what's the purpose to have the standards of care? Due to significant impact of amputation on the person with limb loss, it's very important to provide rehabilitation, different options of rehabilitation, education, prosthetic fitting and training, prevention of complications, to approach person with limb loss by multidisciplinary approach to ensure independency and improve quality of life. How to approach to a person with limb amputation. So first stage should be starting prior to surgery, pre-amputation, then acute post-amputation, then pre-prosthetic training, prosthetic training and fitting, and then the follow-up, which is a lifelong journey. These are the standards of care, and actually this is just a minimum standards of care that should be provided to the person with limb loss. Here I divided the standards of care into service-based standards, which is the blue side, and this is just explaining the process to provide the care. And to person-based standards, which is the orange side, which indicate the care for person with limb amputation, which is care coordination, comprehensive care, counseling and psychological support, peer support, fall prevention, discharge planning, pediatric care. Dr. Faiz will explain more about it. Upper limb amputation, we will have a workshop by Mr. Mustafa regarding upper limb amputation. Care of the residual limb, education across all stages of care, pain management, which is a multidisciplinary approach between the physician and the therapist, and special population. First standard, which is the care coordination. A pre-amputation consultation should be conducted for all planned amputation, even prior to the surgery. This is the ideal, with the surgeon and representatives of all the rehabilitation team involved with rehabilitation care after surgery. So when amputation occurred unexpectedly, for example, due to trauma or any other reason, the surgical team should refer the person to rehabilitation immediately. The person who has undergone amputation should know how to access their specialist team at any stage. The person primary care provider is an important member of the care team and ideally should be kept informed of changing care needs. So the care plan includes information on the person's accommodation, living arrangement, and environment, and this should be taken in the first consultation. The comprehensive assessment and care plan documented the pre-surgical phase of care is reviewed and should be updated throughout the care journey and include the care of the residual limb. Access to specialist interdisciplinary team should be available for all persons undergoing amputation. Counseling and psychological support is the next standard. So grieving is a very normal process. We should not prevent it, but we should provide reassurance to all persons who will go through amputation. A psychological assessment should be completed in the preoperative phase. Psychological functioning is assessed at each phase of management from acute to rehabilitation and beyond. Identify depression and anxiety, post-traumatic stress disorder, symptoms, sexual difficulties, and substance abuse is very important as well. Depression following amputation can result from an adjustment reaction to the surgery and to sudden disability. As there will be different changing in different levels for person with limb amputation, and we need to address that. Post-traumatic stress disorder is common around 20 to 22% after amputation, especially if it is a traumatic cause. For ischemia-related non-traumatic amputation, the incidence of PTSD is less than 5%. Peer support is very important to provide peer support, and ideally should be provided from the acute care to assist people to adapt to the challenges of amputation, promote social inclusion, provide access to information and resources, and to assist people to rearrange with their communities. Fall prevention, so fall risk screening and education should be provided as soon as possible on admission. A balance and fall prevention exercise program should be delivered by a physiotherapist and should be offered to people at risk of falls. Provision of proper assistive devices as early as possible. Rigid dressing, removable rigid dressing can be used for transtibial amputees to help protect the limb in the event of fall, and home safety review should be provided by occupational therapy as soon as possible. Discharge planning. So discharge planning actually should be started from day one of admission. Care for amputees occur across numerous care settings with the numerous healthcare provider. Coordination of care transitions and discharge planning is key to support the person across care journey. Multidisciplinary hospital discharge care plan have a positive impact quality of care. So it will be very nice to meet with the surgeon, the rehab team, the person, the family, and the caregiver to discuss this. There is a high association between continuity of care, health outcomes of the person, and satisfaction. Discharge recommendations and transfer of care plans are provided in writing. And provision of program coordinator for amputee care is very important just to make this journey as smooth as possible to the patient. Comprehensive care, this is another standard. A comprehensive care plan is developed and should be updated through the care journey. A comprehensive assessment that evaluates the person's physical condition, nutrition, pain, cognition, psychological status, social support system should be completed from the first consultation in acute care. The person valued goals and priorities, including independence, preferred activities, and participation, should be documented, as well as everything will affect the opinion and the provision of which type of prosthesis, level of amputation, and so on. Now we will move to the person care standards. First, the care of the residual limb. So discussion with the person about the likely appearance of the residual limb, where their limb will end, residual limb pain, phantom sensation, expected healing time, and potential for prosthetic use should be occur pre-operatively. Immediate post-surgical care, which include education on wound healing, management of the edema, prevention of contractures, and ongoing care of the residual limb. And nursing is very important here and should be educated about that. Again, removable rigid dressing are utilized in transtibial amputations where there are no clinical contraindications. We also have other options like Zimmer splint. Care of the residual limb, again, care and hygiene of the residual limb and contracture prevention should be emphasized in all phases. Education should be provided regarding prosthetic use and fit, sock management, hygiene, weight management, and fluid fluctuation. A plan of ongoing care should be provided and include provision of contact details, the therapy, clinic, and prosthetic if any residual limb issues occur. Education should occur at all stages of care. At the impairment-based level, so we need to educate the person about the residual limb management, wound management, edema control, and so on. And at the level of the environment, interdisciplinary team members and their role, phases of rehab, and peer support. At the level of activity and participation, now this person wants to go back to drive, to work, and to be re-engaged in the community. So we will not only care about the residual side, but we should care about the person as a whole, and to address any problems in the contralateral side as well. If there is a pain, we should manage it. We should provide counseling and coping skills. Chronic disease management is very important. Again, secondary prevention. We should emphasize on diabetes management, which include podiatry management as well. Lifestyle management of risk factors such as smoking cessation. This will help, of course, wound healing, and it will improve the wound healing. Nutrition is very important here in wound healing as well, and weight control, and exercise maintenance as well. Prosthetic and non-prosthetic management, fall prevention management, driving, vocation, and leisure. Pain. So pain should be emphasized in all phases, starting pre-amputation consultation. If there is any pre-existing pain, if the person is already on pain management for any reason, we need to know his medications, the type of the pain, acuity, and we should educate on the possible types of all management of pain post-amputation, like residual limb pain or phantom limb pain. Pre-operative pain assessment is very important, and as a formal plan, clinicians are aware of possible reason of pain. Pain is treated in accordance with established guidelines for post-operative phase. should be monitored and addressed from an interdisciplinary perspective during all phases of care. Associated musculoskeletal pain may develop over time, and it's assessed and treated appropriately. Ongoing review of pain medication, efficacy, if there is any side effects to be addressed. Changes in a person's life rule as well, prosthetic use, functional ability may impact on the person's experience of pain. For example, an athlete and he wants to go back to running, he might face pain or from the prosthesis. We need to address everything in all phases. Special consideration for specific population. Membership of the multidisciplinary team is expanded for persons with special needs. Access to geriatric team expertise to be available for people over the age of 65 is very important. Transition care coordinator to be a part of the multidisciplinary team for young people transitioning to adult services. An exercise physiologist is a part of a multidisciplinary team for people engaged in high physical activities, and there is consideration for their leisure activities. This is an example of a pre-prosthetic training and prosthetic fitting and training. It's actually how the journey should go after discharge. It's ideal to have a multidisciplinary amputee rehabilitation clinic and a coordinator to grab all the patients immediately after discharge from the inpatient to outpatient. So in this clinic, we will address the patient through a multidisciplinary team assessing medical stability, comorbidities, possible medical barriers, functional progress, ejection fraction and cardiac function is very important, especially in transfemoral amputation. Wound assessment and dressing as needed, pain management, again in all stages, psychosocial assessment and support, home environment and equipment, and orthosis if needed. So history and physical exam and functional classification of patients with prosthesis or the K level, and we will explain that later, should be done through this clinic. So is the person is ready for prosthesis at this time, or we need to follow up with him and reassess him again. And if he is or she is ready, decision of prosthesis type to be provided through a multidisciplinary team based on his medical condition. Again, the rehab plan can be provided as an outpatient, daycare, or inpatient, and should be intensive. So he should be seen by physical therapy, occupational therapy, prosthetist, social worker, and mental health, dietitian. If we need support from other departments like ophthalmology, as vision is very important, diabetic clinic, and cardiology. What to consider prior to prosthesis prescription? Amputee mobility predictor, and we will talk about it in a different lecture. Assessing single limb stance, the level of ambulation prior to amputation. So it's very important to know the pre-morbid functional level for our patients to give a hint. Assessing single limb stance, vision, cardiac function, cognition, psychiatric illness is very important. Presence of comorbid conditions. Assessment of upper limbs as well is very important, since he or she might use assistive device. This will affect our decision. Assessment of sound limb, for example, if the person is diabetic and having complication from diabetic neuropathy, and this will affect balance, coordination, and gait. Again, assessment of residual limb is very important. Patient weight, educational level is very important. Availability of social support system, and home environment. As I said earlier, follow-up is very important, and especially for a person with amputation, it's a lifelong journey. Why? So we want to assess if there is any new and ongoing medical issues, pain management, emotional adjustment, progress with functional goal, family and community reintegration, recreational and sport adaptation, vocational options and back to work, need for social services, need for adaptive equipment, back to drive, skin integrity, prosthetic condition and fit, and reassessment of prosthetic gait. Pearls of wisdom. Amputee care is a multidisciplinary team-based care, development of a written comprehensive care plan that's person-centered and based on the goals and values of the person as central to the provision of coordinated rehabilitation program. The care plan should include evaluation from all key members of the care team and address rehabilitation, medical, surgical, and psychosocial issues. The identification of psychological, social, and physical support system that will be available to the person during the rehab process and to help cope with challenges of limb loss should occur as early as possible. And to be updated throughout the rehabilitation process in all phases. Education supports self-management for the individual and all members of the care team. Thank you very much.
راعي الملتقى العلمي سعادة الأستاذ عصام بن عبد القادر المهيدب رئيس المجلس التأسيسي للقطاع الشرقي الصحي، السادة الأطباء والأخصائيين ضيوف الملتقى، حضورنا الكريم، السلام عليكم ورحمة الله وبركاته. في ظل ما تشهده بلادنا المباركة من قفزات معرفية نوعية وإنجازات علمية تاريخية، حتى غدا وطننا نواصل فيه الخطوات، حتى غدا وطنا نواصل فيه الخطوات ونسابق فيه الإنجازات نحو رؤية تملأها الطموحات، تقودنا فيه حكمة خادم الحرمين الشريفين الملك سلمان بن عبد العزيز آل سعود، وتسير بنا همة ولي عهده الأمير محمد بن سلمان أدامهما الله ذخرا وعزا. نرحب بكم في مجمع الأمير سلطان للتأهيل إيفاء الطبي، والذي يشهد اليوم أول فعالية علمية متخصصة، وذلك بالشراكة مع مجمع الدمام الطبي تحت عنوان الملتقى العلمي للتعافي وإعادة التأهيل لمبتوري الأطراف، والذي يهدف إلى مناقشة أحدث المستجدات والمنهجيات من خلال مشاركة نخبة من الأطباء والأخصائيين في مجال إعادة التأهيل للأشخاص من ذوي الإعاقة ومبتوري الأطراف. وخير ما نبدأ به حفلنا هذا آيات من الذكر الحكيم. نسعد الآن بكلمة افتتاحية من مضيف هذا الحدث العلمي الرئيس التنفيذي لمجمع الأمير سلطان للتأهيل إيفاء، الأستاذة رنا جميل طيبة.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. راعي حفلنا سعادة الأستاذ عصام عبد القادر المهيدب، رئيس المجلس التأسيسي للقطاع الشرقي الصحي، الأطباء والأخصائيون ضيوف الملتقى، الحضور الكريم، باسم أعضاء مجلس إدارة جمعية إيفاء لرعاية ذوي الإعاقة أرحب بكم في هذا الصرح التاريخي المبارك، مجمع الأمير سلطان للتأهيل، والذي يحمل في أروقته ذكريات 30 عاماً ما بين عطاء الأمير وجهود المؤسسين وتفاني مئات العاملين المخلصين. إن هذا الملتقى العلمي المنطلق بالشراكة بين مجمع الأمير سلطان للتأهيل إيفاء الطبي ومجمع الدمام الصحي ينطلق من 3 مرتكزات في استراتيجية عمل المجمع، ويحقق 4 من الأهداف العالمية للتنمية المستدامة، ويصب في 6 أهداف في رؤية مملكتنا الطموحة 2030. لذا فإننا هنا لتحقيق رؤية وطن بنور العلم واستثمار التنمية. في الجلسات الحوارية العلمية التي ستقام في هذا الملتقى سيتم تسليط الضوء على المعايير المطلوب تقديمها للأشخاص مبتوري الأطراف والرعاية التي يحتاج إليها من مختلف التخصصات الطبية كخدمات تكاملية، من لحظة تأهيل المريض لمرحلة ما قبل البتر إلى الجراحة، مروراً بمراحل التشافي والتأهيل، وصولاً إلى عودته لمجتمعه وعمله وممارسة هواياته. كذلك سيتم الحديث عن الأسباب المختلفة للبتر والنسب العالمية والمحلية الخاصة به، وعن تأهيل الأطفال مبتوري الأطراف، وعن التحديات الممكن مواجهتها وكيفية التعامل معها من خلال مجموعة من الطرق والأساليب العلمية. وسيتعرف المشاركون على أحدث التقنيات في صنع الأطراف الصناعية من خلال ورش العمل والمعرض المصاحب. وبهذه المناسبة ومن منطلق تخصصنا في خدمة الأشخاص ذوي الإعاقة، نفخر في مجمع الأمير سلطان للتأهيل بوجود مصنع فريد داخل المجمع خاص بالأطراف الصناعية والجبائر، يهدف إلى تقديم الخدمات والمنتجات ذات الجودة العالية لمبتوري الأطراف، حيث تم فيه إنتاج أكثر من 4700 طرف صناعي في السنوات الفائتة، إضافة لقيام المجمع بتقديم 10 خدمات ابتكارية للأشخاص من ذوي الإعاقة. وسعيا لتحقيق أهدافنا الاستراتيجية تم عقد أكثر من 54 شراكة مجتمعية، حتى وصلنا بتوفيق الله إلى إجراء 445 ألف جلسة علاجية وخدمة أكثر من 51 ألف مستفيد. أجدد ترحيبي بكم في هذا الكيان العريق، وأسأل الله أن يكون هذا الملتقى نقلة علمية مثمرة وخطوة أولى نحو تنفيذ سلسلة من الملتقيات العلمية المتخصصة لنواصل الإنجازات ونحقق التطلعات. والسلام عليكم ورحمة الله وبركاته.
نستمع الآن إلى كلمة من تجمع الشرقية الصحي يلقيها الدكتور حسن الزهراني رئيس شبكة الدمام الصحية.
بسم الله والصلاة والسلام على رسول الله. السادة الحضور الكرام، بداية أبارك لنا جميعا إقامة هذا الملتقى العلمي، والذي يهدف إلى توسيع دائرة التبادل المعرفي بين الجهات ذات العلاقة والإثراء العلمي في موضوع التعافي وإعادة التأهيل لمبتوري الأطراف، حيث يحقق الملتقى أحدث أهداف برامج التحول الوطني في القطاع الصحي، وهو تحسين جودة وكفاءة الخدمات الصحية، وهو أيضاً يمثل إضافة علمية نوعية للمشاركين فيه من الأطباء والكوادر الصحية من التخصصات الطبية المختلفة. إن من مرتكزات الرعاية الصحية في برامج التحول الصحي أن يكون الإنسان وأن يكون محوراً لهذا التطور، وأن يكون أيضاً محوراً لتطور الخدمات الصحية لرؤية 2030. أشكر جميع الكوادر والجهود العلمية والتنظيمية والتي كانت محل شراكة مميزة لنا بين مجمع الأمير سلطان للتأهيل إيفاء الطبي ومجمع الدمام الصحي، وهو أحد مكونات تجمع الشرقية الصحي. وآمل أن نسعد جميعاً بنجاح هذا الملتقى ورؤية نتائجه وتوصياته، ونتمنى أن نستمر في هذه الشراكة الفعالة لتثمر ملتقيات أخرى وتكون رافداً علمياً يساهم في نشر الوعي الصحي في وطننا الغالي. والسلام عليكم ورحمة الله وبركاته.
نسعد الآن بكلمة رئيس اللجنة العلمية في الملتقى الدكتورة أمل طناب.
السلام عليكم ورحمة الله وبركاته. أصحاب السعادة من قياداتنا ورعاة الحفل، ضيوفنا الكرام وزملاؤنا المتحدثون الأفاضل، أهلاً وسهلاً بكم في هذا الجمع العلمي الأول للتعافي وإعادة التأهيل لمبتوري الأطراف. لقاؤنا اليوم يعكس مدى التقدم الذي وصلت إليه الخدمات الصحية في مجال التأهيل التي ساهمتم جميعاً فيه كأفراد ومؤسسات. بوجودكم ننطلق إلى حقبة من التطور والعلم لدعم فئة مهمة من المجتمع ونساهم في تحسين جودة حياتهم. بعلمكم وعملكم وجهدكم نستطيع تقديم الدعم لمجتمعاتنا، مساهمين في توسيع الخدمات التأهيلية، مساندين لرؤية هذا البلد العظيم في دعم وتمكين ذوي الإعاقة. يشرفنا في هذا اليوم استضافة نخبة من الأطباء والأخصائيين على مستوى المملكة العربية السعودية في مجال تأهيل مبتوري الأطراف، وذلك للاستفادة من علمهم ومهاراتهم ومعرفة آخر المستجدات في هذا المجال، فشكراً لهم ولجهودهم وبارك الله في علمهم. اليوم نقدم رحلة مستفيد مثالية، بدءاً من قبل عملية الجراحية ومن ثم تشافيه بعد الجراحة إلى تأهيله وتمكينه في مجتمعه. اليوم نستعرض أهم المعايير المطلوبة لتأهيل مبتوري الأطراف. باسمي وباسم القائمين أشكر جمعية إيفاء المتمثلة في سعادة رئيسها التنفيذي الأستاذة رنا طيبة وفريقها في استضافة هذا الملتقى وتنظيمهم المبهر. وكما أتقدم بالشكر الجزيل لرعاة الملتقى الكرماء على دعمهم وعطائهم، وكل الشكر لمنشأة الصرح العظيم مجمع الدمام الطبي التابع للتجمع الشرقي الصحي الأول. هذا الصرح بقيادة سعادة الدكتور حسن الزهراني والمتمثل في إدارة الشؤون الأكاديمية لدعمها المستمر للتعليم والتطوير، ولقسم التواصل المؤسسي على جهودهم، وجميع من ساهم في إنجاح هذا الحدث العلمي. بتكاتفنا جميعاً نصل، فلكم خالص الشكر والثناء.
قصة تستحق أن تروى وتشاهد بكل حب وإتقان، وبأيدي أولادنا وبناتنا من الأشخاص ذوي الإعاقة. صنعت لأجلكم هدايا المذكرات التي تم توزيعها عليكم عند دخولكم إلى هذه القاعة، والدروع التذكارية والتي سيتم التكريم بها في هذا الملتقى. وفي هذه اللحظات المميزة من ملتقانا، وباسم مجمع الأمير سلطان للتأهيل إيفاء الطبي ومجمع الدمام الصحي، نعبر عن شكرنا وتقديرنا لمن ساهموا من أجل إقامة هذا الملتقى العلمي، رعاة حفلنا، الأطباء والأخصائيون المشاركون، شركاء النجاح. بدعمكم المبارك سيثمر هذا الملتقى علما وابتكارا ونجاحا بإذن الله. إن تكريمكم اليوم ليس إلا رسالة شكر وامتنان لما تقدمون من أجل وطنكم ولدوركم المحوري في تحقيق أهدافنا وتطلعاتنا. فليتفضل سعادة رئيس المجلس التأسيسي للقطاع الشرقي الصحي الأستاذ عصام بن عبد القادر المهيدب، ورئيس مجلس إدارة مجمع الأمير سلطان للتأهيل إيفاء المهندس خالد بن عبد الله الزامل، لتكريم الرعاة والأطباء والأخصائيين وشركاء النجاح في هذا الملتقى. رعاة الملتقى: شبكة الدمام الصحية الدكتور حسن بن جار الله الزهراني الراعي الطبي لهذا الملتقى. مجموعة التميمي: الأستاذ طارق التميمي الراعي البلاتيني لهذا الملتقى. شركة السعودية العالمية للموانئ: الأستاذ فريد الغصن الراعي الذهبي لهذا الملتقى. مؤسسة عبد الرحمن بن صالح الراجح الخيرية: المهندس سعيد القحطاني الراعي الذهبي لهذا الملتقى. مجموعة العثمان القابضة: الأستاذ عبد العزيز العثمان الراعي البرونزي لهذا الملتقى. شركة الحدث الدولي لتنظيم المعارض والمؤتمرات: الأستاذ جابر جار الله المري راعي التنظيم لهذا الملتقى. نكرم الآن المجلس العلمي لهذا الملتقى: رئيس اللجنة العلمية الدكتورة أمل فوزي طناب، الدكتور حسين بن علي الجواد. الدكتورة مها بن إدريس. الدكتور فايز بن محمد الشهري. الدكتور محمد بن طاهر سي العربي. الأستاذ عبد السلام بن علي العمري. الأستاذة أسماء بن علي العمري. أسماء بن علي الغامدي. الأستاذ عبد الله بن علي آل عبد الله. الأستاذة زينب بنت عبد الله آل غنام. الأستاذة شروق بنت عايض المقبل. الأستاذة فاطمة بنت إبراهيم الخباز. الأستاذ مصطفى بن عبد الكريم بو 50. الأستاذ ضاري بن داود المبيض. الجهات المشاركة: مؤسسة تحالف الرعاية الأستاذ كمال زين الدين. مؤسسة القيم للتجارة الأستاذ محمد القاضي. شركة إيوان الطبية الأستاذ محمد نسيم. جمعية مبتوري الأطراف الأستاذ ماجد العتيبي. الجمعية السعودية للعلاج الطبيعي سبتة الأستاذة هيا جاسم الدوسري. شركاء النجاح الأستاذ حسام غزاوي. الشريك الأدبي لمقهى ومحمصة شرق الأستاذ علي الزهراني. كلاسيكيات إثنتس الأستاذة الإلهام الصغير. شركة بجة السعودية الأستاذ عبد الله الزهراني. فندق سويس سبريت الأستاذ حسام الزعني. شركة الجميح للمرطبات الأستاذ فيصل السنيد. أما الآن نسعد في مجمع الأمير سلطان للتأهيل إيفاء الطبي أن نقدم تكريم لرئيس المجلس التأسيسي للقطاع الشرقي الصحي راعي الحفل التشريفي الأستاذ عصام المهيدر. نشكركم على دعمكم لهذه الملتقيات النافعة. الآن نترككم مع استئناف الملتقى والجلسات العلمية والفعاليات المصاحبة. ننبه أن الجلسات العلمية مستمرة والفعاليات المصاحبة، فنهيب بالحضور الكريم الحرص على الاستفادة من هذا الملتقى بكل تفاصيله وفقراته. شكرا لكم.
Good morning, everyone, and welcome to today's scientific forum for recovery and rehabilitation in person with limb amputation. We are incredibly fortunate to have a distinguished group of experts with us today who will be sharing their insights on various topics about limb amputation. And I would like to encourage everyone to engage with our speakers, ask thoughtful questions, and make the most of this valuable opportunity to learn from their expertise. I am very thrilled to announce our second speaker for today, who will discuss the ICF model of care management and prosthetics and orthotics. He is a member of a scientific community senior prosthetist and orthotist, and head department of prosthetics and orthotics in the Ífáء Rehabilitation Center. Please join me in welcoming our speaker, Mr. Larin Bale.
Hello, one. Hi everyone. Is my voice clear? Yeah, right? Okay. Hi everyone. I'm really pleased to see you all here in Ífáء. It's a pleasure to have you all. It's my friends and colleagues here. اللهم احلل عقدة من لساني يفقهوا بها قولي. I will start in 2018. Where is it? It doesn't work? Okay. In 2018, my story started when I've been asked by Mark Muller, the head director of our clinic in the US, what will be your dream? I said to him, my dream would be, I go to Africa to help people with amputation, give them prosthetics. I didn't go to Africa, but I achieved my dream. This year, I went to 3 different missions with King Salman Relief. It was really a good journey. It's added too much to me from my spiritual side and the humanitarian side of me. I achieved my dream, but today, if you ask me on this stage, what will be your dream? My dream will be that I see the model of care that we have here in Ífáء, everywhere in the kingdom. The spirit we have in our department, I see it everywhere in the kingdom. So, these 2 pictures, the picture on the right and the picture on the left. The picture on the left, on the right, it was a prize that was given to me when I answered hard questions. And Mark Muller gave me, as a prize, gave me a microprocessor. In 4th of July, all Americans were celebrating the Independence Day. I was celebrating going back home at that date. I didn't have enough space, a room inside my luggage to get this knee inside my luggage. And I said to myself that, I will go to Saudi and I will do a lot of microprocessor. Why I keep this prize with me? So, I will leave it there. And I left it. And when I arrived to Saudi, I saw a lot of patients coming to us in our department with 2 different kinds of prosthetics. Mechanical knees and a such foot. And I asked myself, okay, Tari, what you have been studying? What you are doing with this? So, nowadays, the picture on the left is for 3 different prosthetics. I took this picture like 1 month ago. And these 3 different knees, one from France, High-Tech, the other one is from 3R60 from Auerbach, Germany, and the third one is a microprocessor from Rio from Osher. So this achievement was done by the spirit we have in the department. I work with really great people that try to serve the people of disability every day. And why I brought this picture of 3 different knees? Why I use these different knees, how I use them, why, what, when I use them. This is the question, this is the right question. And this question can be answered only if we go with a right model, a right framework, like ICF, that takes the patient's from all of the domains. That's how he can get back participating in the community. The history of ICF. It started in 1960. They start, the World Health Organization tried to figure out a framework related to the health. And they started with the ICD, the International Classification of Disease. And when you see a disease is a problem, but what is the solution? Where is the participation? They tried to improve and evolve this model of care, and in 1980, they go with the International Classification of Disability and Impairment and Handicapped. But it's so, sounds so negative in a bad way, handicapped. Like, how you will get this patient participating back to the community if he's a handicap. And in 1993, when I was born, the WHO started trying to improve the model. And in 2001, they finally finalized the ICF, the International Classification of Functional Disability. And this framework go with 5 different key domains. It goes with the health condition as ICD-10, and then it goes with the body and function and structure, the anatomy and physiology of the patients. What is the range of motion and what's going on with all of the muscular, the MMT, the tissues around the stump. And goes with activities, with the outcome measure, for example, like a K level. Okay, why I should use this kind of prosthesis? This was made two weeks ago. Why we use a locked knee that's open with a cable? Why? Because this patient has no manual has no MMT, has like grade 3. This patient has no high active. He's a household ambulator, K1 level. That's why we use this. That's why we go with this framework to know what device that we have to manufacture for the patient. So, and we go with the participation. What is this guy a sporty guy? Going with a lot of sports, like as a K4? Does he need a 3S82 with a blade sprinter with our cheetah, like in OSHA? What he needs exactly? Like this should be manufactured through the manual muscle testing, the environment of the patients, what hinders the patient going back to his active daily living, what facilitates the patients from an environmental standpoint of view. So, and through ICF, you can see the right framework to help the patient going back to the community. So, with all of these domains, there is a codes, more than 1,400, 1,400, like 1,400 in American way. So more than 1,400. So these codes used to know how the multidisciplinary team can go together to give the patients the ability to participate in the community. Oh, like example, walking. What's the department that related to the walking? Oh, physical therapy, BMR, physiatrist, diagnosing the patient. All of this framework can go with a blueprint that they can follow to get the patient participating back to the community. And here is everything in this life start with why for me. Okay, why ICF? ICF, one of the things that we have in Saudi, and one of the things we practiced before in the US to get the insurance giving a reimbursement for the patient from insurance, we did a lot of paperwork. And one of the paperwork was ICF. Why we do a lot of paperwork? Because when you go to the insurance company, they cannot neglect you and say, oh, no, we will not pay for this patient. Why you will not pay? This is the outcome measure. This is the function of the patient. This is his K level. This is the device can get him back to the life. This is the quality of life that the patient is seeking. So they will reimburse you upon this. The ICF, which will give a good cause for the insurance company to give you the money back. And also, it's a database utilizing the data. The people can go in a framework where they go with a good data for them. And this is one of the things that we don't have in prosthetics and orthotics. It was like a craziness when you want to go in prosthetics and orthotics and you want to write a paper. There is no literature review, to be honest. And we have to empower this kind of habit. And the other thing also is a holistic approach. It's a personal care. The patient himself go with you with this framework, knowing what he wants to participate back in life and where to go in the environment. And this is a study. It's not so far. It's in Lebanon. This outpatient clinic used the ICF as a role model to care about the people. And they conclude that 85% of the people who did ICF participating back to the community, they did a good result. 15% of them, they went back to inpatient. But the ICF give you a good framework and domains to do a good outpatient practice. And the other one was used for 100 patients. They used the ICF in a prosthetics and orthotics unit, and they saw a good result. That's giving the practitioners and the patients a good framework to know what they want. And here is the most important study for me. This is a study of BIF. The BIF tries to screen and know what is the supply demand of prosthetics in Saudi. And this was a shocking result. The shocking result was in a study inside this study that 3,775 patients, 66%, 2/3 of them, they didn't get any rehabilitation intervention. So, and when we want to try to conclude all of this, and I saw in the study they concluded what was the reason. They said the reason is unknown, and from a deductive way, بشكل استنباطي, in a deductive way, that why that's happened, because there is no clear beneficiary journey for the patient, and this is craziness, and we cannot go with this for a long period of time. So, and this study suggests that there will be growth in prosthetics and orthotics demand 8.6 in Saudi. Are we ready? I will leave it for your imagination. And here's the last picture. The lecture where I build my dreams. As an individual, I'm talking from a subjective way. And I would thank everybody here. Ms. Rana, Dr. Shi'arabi. I would like to thank my teacher, Dr. Muhammad Nasser, Muhammad Hussein, Ihab, Safdar, Abdul Rahman, Fahad. I work really with a good team that inspired me. And I'm the youngest guy in this team. And I would thank to Arwa too. I'm the youngest guy except Arwa. She's younger than me. But so I'm the youngest guy. I'm the servant to achieve the goals. And as we say in Arabic, صغير القوم خادمهم. Thank you. Now we will introduce أستاذ ماجد العتيبي of بتور. حياك يا بدي. ابشر. تبيني أعطيك هذا أحسن لك ولا؟
السلام عليكم. سعد الله صباحكم كل خير. شكرا لكل من نظم ورتب وحضر، وشكرا للجميع على كل ما يقدمونه في خدمة ذوي الأطراف المبتورة. طبعا ماجد العتيبي رئيس مجلس الإدارة بجمعية رعاية مبتوري الأطراف. هالجمعية أنا أول شيء بعلمكم كيف تأسست الجمعية وليش تأسست، وبحاول باختصار بشكل سريع وبأشرح لكم معظم مشاكل ذوي الأطراف المبتورة اللي يواجهونها فترة التأهيل، سواء في العلاج الطبيعي أو الأطراف الصناعية. طبعا أنا تعرضت لحادث مروري قبل 14 سنة، يعني عمر شاب الحين في المتوسط، هذه مدة إصابتي. أول ما انبترت رجولي دخلت غيبوبة، جلست شهر في الغيبوبة، بعدين انتقلت للعلاج الطبيعي، والحمد لله يعني الفرصة أني دخلت العلاج الطبيعي ما يعتبر ذاك الانتظار، أني انتظرت فترة طويلة، وهذه من فضل الله عليه الحمد لله أني دخلت فترة العلاج الطبيعي بشكل سريع. طبعا كان عندي عدة مشاكل. في بداية البتر كان وزني ثقيل فوق 100، وهذا تحدي صعب أمامي. أذكر يعني أول ما دخلت مركز التأهيل، ومركز التأهيل ذاك الوقت يعني في قمة من المعرفة ودراية بكيفية التعامل مع الأشخاص ذوي الأطراف المبتورة. ومن فضل الله علي أن مدير التأهيل الطبي ذاك الوقت الآن ترى موجود هنا، دكتور محمد سي العربي، تحية، الله يعطيك العافية، ويجعل كل ما قدمته الآن من جمعية ومن خدمات لذوي الأطراف المبتورة في ميزان حسناتك وحسنات الإخوان والزملاء في التأهيل اللي مروا بتأهيل. فالشخص أي شخص سواء عنده بتر ولا إصابة أخرى ما ينسى فضل اللي تسبب في إعادة تأهيله وساعده، وكان سبب كبير في أنه يدعمه حتى أنه يتخطى المشكلة اللي هو فيها. فما كنت أعرف شيء عن الأطراف الصناعية، ما كنت أعرف شيء عن العلاج الطبيعي والتأهيل، معلم سابقا ما أعرف شيء عن الجانب الصحي. فجأة لقيت نفسي في فاقد رجولي ولا أدري وش الأطراف، حديد قدامي ما أعرف شلون أستخدمه، هل أنا أقدر أمشي ما أقدر أمشي. أنا أستبعد في نفسي والناس تبشر، والمقاطع الفيديو أشوفها زينة، لكن نماذج مهم في السعودية برا، وأقول ممكن التأهيل برا أحسن، داخل أحسن. فجانب مهم الشخص أولا هو اللي يصنع النجاح. فإذا كان تعرفون يعني الأشخاص مختلفين تماما عن بعض، فيهم اللي مجتهد، فيهم اللي نص ونص، فيهم اللي مركز في تأهيله، فيهم اللي يستوعب الكلام اللي بيصير له، فيهم اللي عنده يعني إلحاح أنه يتجاوز المشكلة اللي هو فيها ويصر، وهذا هو اللي يمشي بسرعة، وفيهم اللي جات ما جات خلها تمشي وتعدي، وهذه مشكلة كبيرة. فأول ما دخلت التأهيل تحت إدارة دكتور تأهيل مع، وركزوا في كلامي، إدارة دكتور تأهيل مع أخصائي علاج طبيعي، مع أخصائي أطراف صناعية، مع أخصائي العلاج الوظيفي، مع أخصائي النفسي، مع الدايتيشن اللي هو أخصائي التغذية. هذول الخمسة من بداية تأهيلي حتى نهاية تأهيلي هم متابعين بشكل مستمر، بداية بالتخصص النفسي، أني أتقبل إعاقتي وأتقبل المشاكل اللي قدامي، بعدين مجرد ما أتجاوز المشكلة النفسية خلاص، ترى 70% المشكلة النفسية، 70%، الباقي كله على العلاج الطبيعي والأطراف الصناعية والتغذية. يعني شيء لا يمكن أنك تستغني عنه، لا يمكن أبدا أنك تستغني عنه. الجمعية ولله الحمد بعد ما يوم أسستها لقيت نقص كثير في خدمة المبتورين. ذاك الوقت كنت في المركز ولله الحمد، هذا من فضل الله علي أيضا أني تأهلت في مركز كل هالمشاكل ذي اللي أنا يواجهها الشخص المبتور حلها لي. فبالشيء اللي أنا تجاوزته ولله الحمد ما يرضيني أبدا أن زملائي من ذوي الأطراف المبتورة أنهم يبقون ولا يتعنون، وهو المشكلة لها حل، ما فيه مشكلة وما لها حل، وحلها بسيط، أن يكون فيه برنامج فيه معايير يمشي عليها ذوي الأطراف المبتورة، بداية من التشخيص الممتاز للشخص المبتور على حسب قوته وعلى حسب نشاطه البدني وعلى حسب استيعابه يحدد نوع الطرف حقه. ما هو بأجيب لي واحد عمره 20 وأعطيه طرف حق شايب في عمر 60، هذا من أكبر المعيقات. غير كذا يعني الدعم النفسي مهم، فلذلك الجمعية طبعا مع الأيام ومع السنوات قدرت أني أجمع داتا من المملكة وأيضا حتى من الخليج. الآن أنا عندي جروبات من الكويت، البحرين، من قطر، من الإمارات، من السعودية، وقدرت أني يعني أشوف أبرز المشاكل اللي يواجهونها والأشياء اللي كيف نقدر نحلها، كيف نقدر نحل المشاكل اللي احنا نواجهها. فكانت المعضلة الكبيرة توفير الطرف الصناعي، العلاج الطبيعي، هالشيئين الأساسيين. فيهم ناس يقول أنا الجانب النفسي ما عندي مشكلة، أنا نفسيتي جاتني من ما لقيت أخصائي أطراف صح، ما لقيت أخصائي علاج طبيعي يدربني صح ويتناول المشاكل اللي أنا مش معقولة. فيه موجود، فيه ناس موجودين، ولكن متى يكون فيه برنامج كل الفريق هذا الخمسة اللي أنا قلتهم قبل شوي يمشون في مسار واحد مع الشخص اللي عنده بتر. ترى أنا مسميني أبو حدرية، فإذا منك انتهى الوقت. الخمسة الأخصائيين ذول اللي يمشون مع المريض لازم أنهم يكونون يتوفرون في نفس مركز التأهيل، مع جودة الأطراف، مع الماتيريال اللي تستخدم في تصنيع الطرف الصناعي، مع نوع الطرف الصناعي اللي يستخدم للشخص اللي عنده بتر. ترى الكلام اللي أنا أقوله ما هو أنا شخص واحد، أنا أتكلم عن جميع المبتورين في المملكة بل في الخليج، ولله الحمد. الآن في المملكة عندنا يعني نعتبر أفضل الموجودين، الخدمات المقدمة تعتبر أفضل الموجود، ولكن نبغى شوية تركيز، نبغى شوية تركيز. أنا يوم أني أتكلم عن العيوب ما هو من باب أني يعني أثبط، من باب أن نحسن. أنا كتجربة مريض أبغى أنقلها للأخصائي الدكتور، عشان هو بآلية العمل عنده يعرف وين المشاكل اللي يواجهها مبتوري الأطراف ويقومونها ويحلونها. أعرف أن الأمور متشعبة، ولكن ما هو بصعب حلها، والله ما هو بصعب حلها أبداً. وبعدين من ضمن الأشياء يعني الشخص اللي عنده بتر تلقاه موظف، تلقاه عنده أعمال، تلقاه ربة منزل، تلقاه طالب يروح المدرسة يروح الجامعة. أنا مستحيل أني يعني أروح المركز يخرب علي الطرف تندمر باقي أمور حياتي، يتعطل علي عملي، يتعطل علي مدرستي، تتعطل علي الجامعة، تتعطل علي رياضتي اللي أنا أمارسها بالطرف الصناعي. فشيء مهم جدا أن نحل هالمشاكل ونحاول أن نتوعى. طبعا شركات كثيرة، يعني ما أخفيكم جمعية رعاية مبتوري الأطراف هي الآن على مستوى المملكة وتخدم جميع مناطق المملكة، ويعني شركات كثيرة للأطراف الصناعية جونا قالوا حنا نبغى نستلم المرضى اللي عندكم ونصنع لهم الأطراف. فإذا ما فيه معايير مثل ما قلت لكم قبل شوي، تكون أطراف صناعية مع علاج طبيعي مع دعم نفسي مع برنامج كامل لمبتوري الأطراف، مستحيل أن يعني أن نتوافق في الشيء هذا، أو مستحيل أنا كشخص يعني مريت بتجربة ناجحة أني أعرض زملائي الباقيين لتجربة مو بزينة أبدا. لازم يا أما نمشي في الهوى سوا وفي الخط واحد وصحيح، أو أن نتجنب الطريقة الخاطئة أو التقليدية على أيام زمان. حنا في عصر يعني التقدم، كل شوي الأطراف الصناعية في تقدم، في تطور، في يعني أشياء جديدة تطلع، وحنا المال موجود، العلم موجود ولله الحمد، ناقصنا بس شوية تركيز والتطبيق النظام بكامل حذافيره. طبعا شوف كيف الأثر اللي يرجع على الشخص المبتور إذا من صار له يعني نجح في حياته بعد الطرف الصناعي وأبدع في الأمور اللي ما ينسى. والله العظيم أني ما أنسى الفريق اللي أنا مريت تحت تأهيلهم ذاك الوقت، ولا أنسى كل الأشياء الزينة اللي مرت علي في فترة تأهيلي، لأنهم شالوا إنسان كان فاقد الأمل من المشي، من الحركة، من العمل، من كل شيء، إلى أن الشخص رجع زي ما كان وأحسن من مكان، وقدر يعيش حياته، وقدر يمشي، وقدر حتى يعني يسعى لمساعدة الآخرين. فأتمنى من الجميع، أنتم كممارسين صحيين تراكم على ثغر والله لا يقل أهمية ولا يقل يعني قدر عن حماة الوطن واللي يدافعون عن الوطن، لأنكم أنتم جالسين تحيون ناس فاقدين الأمل، تحيون ناس تلقاها حياته من دمرك كلها يعني فاقد الأمل مرة. ترى في حالات طلاق يجينا في الجمعية ناس يقول أنا عندي حالة طلاق، يا أما أركب طرف الآن ولا أني ما أمشي. الأسبوع الماضي يعني وهذه حالة يعني بقولها لكم بدون ذكر أسماء، وأنا أمشي دائما كل يوم لازم أروح أمشي 4-5 كيلو بشكل يومي، وأنا رايح أمشي والقى لي شايب عمره تقريبا 65-66 عنده بتر تحت الركبة بسبب السكر. من وين يا عم؟ أشوف الطرف حقه تو تجريبي. من وين يا عم؟ قال من طريف. جاي أنت ساكن هنا ولا أساسا؟ قال لا والله جاي عندي قبل أسبوعين جيت أخذت مقاسات الطرف ورجعت، واليوم جيت ركبت الطرف وراجع اليوم. سويت علاج طبيعي؟ قال لا. إيش العلاج الطبيعي؟ قلت عطوك سيليكون، ورني الطرف حقك. كان حاطه في الكرسي، طلع السيليكون يوم طلع السيليكون اللي هو مفتوح يعني ما هو بوضعه الصحيح. قلت الطريقة ذي خطأ، علموك فيها؟ قال لا. قلت كم تلبسه؟ قالوا البسه وامش. عطوني الووكر قالوا يلا امش. بس قلت بس لا، شلون بيتعلم؟ شلون بيتعلم؟ بتر تحت الركبة وشايب عمره 65، حتى لو عمره 70-80، هذه بالطريقة الصحيحة؟ أبدا لا. وين التأهيل قبل الطرف؟ وين التأهيل أثناء استخدام الطرف؟ وين كلموك طيب يعلمونك عن شيء؟ قال أبدا استخدم الطرف. قلت الطرف ده طيب متى الطرف النهائي؟ قال وش الطرف النهائي؟ متى الحاضنة النهائية؟ قال ما أدري. متى تلبس؟ ساعة، ساعتين، 3 ساعات. أنت معك سكر؟ قال إي مع سكر. علمته بالطريقة دي كلها؟ قال الله يجزاك خير، والله إني ما علموني بشيء من الكلام اللي قلته. فكيف تبغون الشخص اللي عنده بتر يستفيد؟ ما تخافون من دعاء المسلمين؟ إذا من أحد دعا على أخصائي ولا على رئيس قسم ولا على أيا كان، تراها تشمل، والله العظيم تشمل. أنا عندي بتر وتعلمت الشيء الصحيح، أتمنى أن كل شخص أنه يتعلم الطريقة الصحيحة. هذه تراها قصة نجاح، قبل ما تكون إلي تكون لك أنت كممارس صحي وكدكتور تأهيل، قصة نجاح لك. يا أخي لما تشوف شخص ناجح في حياته وأنت سبب في هالشيء، بالله ما تسعد، بالله ما ترتاح نفسيا، تجيك البركة في مالك وفي عيالك وفي وقتك اللي أنت تقضيه. هذا الشيء أنا ما أقوله يعني من باب أني أقل من أحد، لا، لكن أقول الشيء هذا من باب شحذ الهمم، وأن الواحد أنه يعني يحتسب الأجر ويفعل اللي بينه وبين الله سبحانه وتعالى، ويعرف أنه في يوم من الأيام ما تدري تدور الأيام، تكون في يوم من الأيام في مكان هالشخص. تتمنى أن أحد يخدمك بالطريقة الصحيحة، وأنت عارف الطريقة الصحيحة ولا تلقى الخدمة الصحيحة، فهذه مشكلة. هذا ما حبيت إني أقوله، حبيت إني أوضح لكم. والكلام اللي أنا أقوله ترى ما أقوله باسم شخص، تراني أتكلم عن مبتوري الأطراف في المملكة. والله يحفظكم جميعا ولا يريكم مكروه. طبعا هالمبادرة الجميلة الملتقى يشكرون عليها مركز إيفاء، مجمع الدمام الطبي والداعمين الله يجزاهم خير. وأنا من يعني المنبر أحث الجميع على أن يكون في تحالف سنوي لذوي الأطراف المبتورة، ويكون كل سنة في مدينة أو في منطقة. يا ليت الشيء.
وهذا اللي قاعد نشتغل عليه بإذن الله. أبد حياك في ديسكشن بانل الحين بين الدكتورة أمل، حياك الله، تفضل. سلام، ساعدني بس. دقيقة بس، خلينا ناخذ البانل محسن، بس خلينا ننزلهم تحت. محسن زبدة سبيكر حقك ما ادري وينه. دقيقة تفضلي دكتورة. Can I get the other one? Do you have the other one? Yeah. Thank you. تفضل. طبعا حياكم الله مرة ثانية. في بس كويك ديسكشن بانل، إذا كان عندكم أي أسئلة بالنسبة لمحاضرة الدكتورة أمل، أو أي أسئلة لي، أو أي أسئلة الأستاذ ماجد العتيبي. بس قبلها بأسأل أنا كم سؤال نفسي للدكتورة أمل والدكتور ماجد العتيبي، وببدأ بالدكتور ماجد العتيبي. أستاذ ماجد العتيبي، بالنسبة لجمعية بتور، وش الدور القائم بشكل مؤسسي لجمعية بتور؟ هل هي جمعية خيرية؟ هل هي تشريعية؟ هل هي تدخل بالليجستراتيف بالقوانين؟ وش الشيء اللي أنتم الكور بزنس حقكم وش تسوون بالضبط؟
طبعا جمعية رعاية مبتوري الأطراف هي جمعية من أهدافها أولا هي جمعية صحية تحت إشراف وزارة الصحة، تركيب الأطراف الصناعية، العلاج الطبيعي، الدعم النفسي لمبتوري الأطراف، الدمج في المجتمع لذوي الأطراف المبتورة، ومن بينها توظيف الأشخاص ذوي البتور.
نعم. جميل. وبالنسبة لك دكتورة أمل، وش الشيء اللي أنت تشوفينه ممكن يساعد في الفيلد اوف بروستاتكس اند اورثوتكس كطبيبة تأهيل، كليدر للفريق الطبي القائم على التأهيل؟ وش الكي بوينتس اللي تشوفين من خلالها أنا بستفاد منك الحين، وأنا قاعد على البنر هذا بستفاد شيء ممكن نطبقه عندنا في مجمع الأمير سلطان؟ وش الشيء الكي بوينتس الموجودة اللي ممكن أنها تغير الأطراف الصناعية والأجهزة التقويمية في السعودية؟
أنا أعتقد أن يكون في تأسيس كامل إلى التيم، عيادة فيها من جميع الأقسام، مثل ما تفضل الأستاذ ماجد، من الطبيب والأخصائيين.
حلو.
ويكون يتم التقييم من التيم كامل. طبعا قبل هذا كله أنا أشوف أول شيء لازم إحنا ننشر الوعي بأهمية المجال هذا وإنها خدمة تكاملية، هذا أهم نقطة. وابتداء أشوف حتى من الجامعات الطلاب الستودنتس، لأن هم الجيل الجديد اللي راح يعني يبدأوا يغير، خلينا نقول يصنع تغيير عن الروتين، خلينا نقول السابق، صح ولا لا؟
نعم.
وبرضو إحنا كناس ماخذين هذا التخصص المفترض ننشر الوعي على مستوى المستشفيات، على مستوى الأقسام، على مستوى حتى الجراحين، يعني إنه في خدمة زي هذه إحنا المفترض نبدأها حتى قبل عملية البتر لو كانت العملية يعني بلاند. فأنا أشوف هذه أهم نقطة، نشر الوعي صراحة.
وهذا شيء ممكن نقدر نتساعد فيه مع أستاذ ماجد العتيبي، لأن ما شاء الله تبارك الله جمعية بتور من الجمعيات القائدة بالنسبة للوعي، وهذا شيء أنا أشوفه كواحد من الناس اللي موجودين في الكوميونتي الموجودة، إنه جمعية بتور بالنسبة للمستفيدين حقها، حتى إذا جاك من جمعية بتور يجونك المستفيد، وهذا شيء شفته إنه فاهم هو شبي. وأستاذ ماجد شكرا جزيل الشكر لنشر الوعي هذا. بس إنه مو السؤال، الحث كالآتي: تضافر الجهود إن الناس تبدأ من حيث انتهى الآخرين. هاو إنه كجمعية بتور، هل أنتم ممكنكم أنتم تعاونتوا مع مؤسسات حكومية، مع أشياء موجودة؟ ليه؟ لأنه هل نمبرز موجودة، أرقام موجودة، قوائم موجودة تقدر تفيد فيها صانع القرار الموجود، مثلا وزارة الصحة، موجود مثلا بالCHI اللي هو الكونسل اوف هيلث انشورنس اللي هو مجلس الضمان الصحي. أحس إنهم يحتاجون دعمكم. هل أنتم قائمين على هذا الشيء أو لا؟
طبعا
بس دق الزر شغال.
طبعا
خلاص.
مبتوري الأطراف ترى ما هو بالمبتوري فقط، ترى ما عاد في أحد جاهل أبدا، والله ما عاد في أحد جاهل، لدرجة أن الشخص اللي عنده بتر بيسأل وبيعرف، حتى لو ما عرف من أول مرة بيعرف المرة الثانية من كان أخصائية ومن كان القسم اللي هو يعالجه، وكيف الأثر النفسي اللي بيصير عنده. والشيء ذا مرينا فيه احنا كجمعية كثير، ومريت فيه أنا أثناء فترة تأهيلي. أنا صراحة درست العلاج الطبيعي قبل ما نأسس الجمعية، وكان يجينا ناس من شتى مناطق المملكة، اللي من الغربية، من الشرقية، من الرياض، من الجنوب، من الشمال. شوف كيف كم شخص عنده طرف. كان عندنا كمية هدر، وتوقع لا زالت لكن قلت، كمية هدر كبير في الأطراف الصناعية. تلقى الشخص الواحد، أعرف واحد عنده حوالي 6 أو 7 أطراف، يقول والله ما استخدمت ولا واحد. أكثر استخدام ممكن 2 3 لين جاء في المركز التأهيل اللي أنا كنت أعمل فيه، وركب الطرف الصناعي وضبطت معه. وهذا دليل على إيش؟ على أن فيه برنامج يتناول جميع أمور الشخص اللي عنده بتر، ما يركز على جانب ويترك الجانب الآخر. ترى خطأ أنك تركز على جانب علاج طبيعي وتترك الطرف الصناعي بحالة سيئة، أو أنك تركز على طرف صناعي بجودة عالية وبدون علاج طبيعي، وقبل هذا كله ما في الدعم النفسي. الجمعية كان عندها شيئين أساسيين، اللي هو دعم الخبراء بتور. الحين أنا أول ما صار علي البتر وصحيت ما في ولا واحد عندي شخص عنده بتر، ولا أعرف ولا واحد، إلا لما دخلت مركز التأهيل، وكانوا هذا شايب أصغر من سني، وهذا بتر تحت الركبة، وهذا بتر رجل واحدة. كنت ما أشوف إلا نادرا أشوف واحد بترين، إذا شفته خلاص تمسكت فيه. يوم بديت وأقعد أفصفص أبدأ معه من البداية، وش سويت، وكيف تجاوزت، وكيف سويت. هذا ممكن عشان أنا، لكن شخص ثاني ممكن يستحي. أعرف مريضة عندها الفانتوم بين لها 17 سنة وهي تحسب أنها تتوهم أنها مشكلة نفسية عندها، 17 سنة تتحمل الألم. وشلون؟ ما أدري.
وهذا في مثل يقول، في مثل ممكن الأطباء اللي هنا راح يزعلون علي فيه، يقول لك اسأل مجرب ولا تسأل طبيب. فإنه الفكرة إنه هذا الشيء يجي من اللي هو صوت الإنسان اللي قاعد يتعب كل يوم. وأنا أحييك على الصوت هذا، وهذا الصوت مسموع. وبالنسبة لي كشخص كفرد من مجتمع، أنا أسمع الصوت أبدالي من أسمع أي صوت ثاني. فإنه لكن سؤالي كالآتي، إنه هل من جمعية بتور وهالجهود الحثيثة هذه اللي أنتم قاعد تعملون عليها بطريقة مرة رائعة، أنه هل في عمل مؤسساتي يكاد يبنى بطريقة موجودة في السعودية مع الجهات اللي موجودة، الجهات التشريعية والجهات التنفيذية اللي أنتم ممكن تشتغلون وياها على أنكم تظفر فيها الجهود؟
طبعا في البداية صعبنا، يعني تعب علينا كثير أن نحصل داتا معينة لذوي الأطراف المبتورة في المملكة.
حلو.
أبدا ما حصلنا. رحنا لوزارة هيئة الإحصاء، رحنا لوزارة الصحة، وزارة الموارد البشرية. آخر شيء قبل تقريبا مؤتمر الصحة العالمي اللي قبل حوالي 3 أسابيع، واجهنا معالي الوزير سألناه نبغى إحصائية لمبتوري الأطراف في المملكة. قال ما فيه، حنا نبغاها منكم، أنتم ابحثوا وسووها. طبعا وش اللي بدورنا تقريبا لنا 4 سنوات قاعدين نسوي حملات تسويقية للجمعية، قاعدين نوضح، نزور المراكز التأهيل، المستشفيات، جهات الإيواء ذوي الإعاقة، الجمعيات الأخرى. وهذه من رؤية المملكة 2030 أنك تسعى للتشارك مع الجهات الأخرى اللي قد تتلاقون في نفس الخدمة. فحصلنا عدد ما هو بسيط، تقريبا فوق 900 الآن، والعدد في ازدياد. يعني كل أسبوع تقريبا من 2 إلى 5 يسجلون عندنا مبتوري أطراف جدد، فيهم اللي حديث فتر وفيهم اللي مبتور من فترة ولا كان له يعني ظهور للمجتمع. هذا اللي الطريقة الوحيدة اللي احنا قدرنا أن نجمع فيها عدد مبتورين بالتعاون مع بعض المراكز، المدن الطبية مثل مدينة الملك سعود، مدينة الملك، مدينة الأمير سلطان الإنسانية. حاولنا أخذ مجموعة من مبتوري الأطراف، المستشفى الجامعي، نحاول قد ما نقدر أن نحصل على عدد مبتوري الأطراف. طبعا الجمعية توفر كل الخدمات الصحية للمبتورين، ما في ذلك يعني
حقائب البتور اللي استفدنا احنا، اللي بنستفاد منها مرة رائعة، جميلة جدا. حقائب المبتورين جدا جميلة،
حقائب
الصحية
خصوصا
جدا جميلة.
هل في فروع إلى جمعية بتور في المملكة بشكل عام، ولا هي الفرع الأساسي بالرياض؟
طبعا أول ما رخصت الجمعية كانت مرخصة على منطقة الرياض فقط، بعد سنة رخصت على جميع مناطق المملكة. السياسة الجمعية الآن أن نحاول أن يكون كل جمعية أو كل مركز خاص بالأطراف الصناعية أو كل مدينة طبية في أي منطقة تكون هي فرع بتور في ذيك المنطقة.
وعلى كذا أستاذنا، هذا شيء عظيم وجميل مرة. كشخص كفرد أشكركم على الشيء اللي أنتم قاعد تسوونه. ومحسن أظن زعل علي، جوالي بحضني وأذاني، وقت انتهى، فأنه قبلها أبي أسمع من الناس، وهذا هو أهم شيء، اللي عنده أي سؤال أو أي إضافة ممكن نثري فيها الدسكشن هذا وننهي بطريقة مرة جميلة. فاللي تفضل، إذا أحد عنده سؤال شيء please feel free to ask. أبد أنا أجيب لك المايك، بس أروح back and forth. Do you have the other mic? Hey, where's the other mic? It doesn't work? Doesn't work. Do you change it? Okay. لا إله إلا الله.
السلام عليكم.
السلام.
أنا حبيت نشكر الأخ مجد العتيبي مساهمته للمبتورين، لأن من زمان اشتغلنا معه، وكل ما يكون واحد مبتور جديد يعطي، لما يشوف كيف ماجد يتصرف، كيف ماجد يمشي، كيف يعطي بعض تشجيعات للناس المبتورين الجدد بصراحة فيها آثار إيجابي 200%. بصراحة الناس كل تأخذه كمثال، ولما يشوفوه مبتور فوق الركبتين أوكي رغم الصعوبات ما هي بسيطة، ماجد يمشي ويشجع الآخرين كأنه هو موش مبتور.
مثال لنا كلنا دكتور.
نعم
هو مثال لنا كلنا
والله. بصراحة نشكره الشكر الجزيل لدعمه للآخرين. شكرا يا ماجد، وتبقى مثال لجميع المبتورين في المملكة.
شكرا دكتور محمد، شكرا جزيل الشكر.
لأنه كلمة اليوم هي اختصرت صراحة المؤتمر كله فعليا، يعني ما شاء الله، يعني الله يعطيك العافية.
ويهمني سؤال، في أحد هناك رفع يده. سؤالك وين المايك؟ تفضل.
السلام عليكم.
السلام ورحمة الله.
يعطيكم العافية على هذا المؤتمر الجميل يعني، ويعطيكم العافية دكتور آمل، الأستاذ ماجد، وأخوي ضاري. سؤالي هو يعني أخوي ضاري، ناقشت أنت شيء جميل يعني اللي هو نظام ال ICF وكيف نظامه اللي هو International Classification of Disease. فسؤالي أنا كCPO معك في المجال، إيش نظامك يعني أو الستيجز اللي تتبعها في ال ICF في CPO فيلد الPO فيلد من يوم ما يخش عليك البيشنت؟
سؤال مرة جميل. السؤال هو بالبداية هو في رحلة مستفيد موجودة تبدأ من طبيب التأهيل. طبيب التأهيل يحول لنا المستفيد عندنا في المكان هذا اللي نحن نعمل فيه هو one stop shop، هو مكان واحد فيه الخدمات التأهيلية موجودة بشكل متكامل، اللي هو عندنا الاوكيبيشنال ثيرابي، البي تي اللي هو الفيزيكال ثيرابي، اغلب الديبارتمنت موجوده. لما يجيني المستفيد انا ما قاعد اقدم له سيرفيس بروفايدنج، انا ما قاعد اقدم له خدمه كتاهيليه بس، انا قاعد احاول قد ما اقدر اي كاستمايز، اسوي له طرف صناعي فيتس هيز نيد. مثلا ابدا وياه في اوتكم ميجرز معينه، ابدا وياه بالكي ليفلز المعينه، من خلال الكي ليفلز اشوف الستور اللي موجود عندي، من الستور الموجود عندي اخذ له الكاست، بعدين يدخل في اللاين اوف برودكشن اللي موجود عندي في الدور الثاني. اللاين اوف برودكشن حق اللي هو البرودكت، المنتج اللي اسويه يكون كاستمايز للنيد اللي موجوده له، مع الكولابريشن اللي موجود مع الديفرنت ديبارتمنتس اللي موجوده عندنا في المكان. فمن خلالها تقدر يجارنتي انك البيشنت هذا he will get participating back to the community. فور اكزامبل في النقطه التاسعه اللي موجوده عندنا في اللاين اوف برودكشن، عندنا اللي هو الجيت البارالل بارز الموجوده داخل المكان حق الجيت اسسمنت هذا، عندنا فيها درج، والدرج فيه ديكلاينر. فانا احرص قبل اطلع المستفيد من عندي انه هو صاعد الدرج وهو نازل من الانكلاينر اللي موجود عندي، فانه احاول قد ما اقدر اني النشاط للمستفيد على الجهاز اللي انا اصنع له اخذه بشكل شمولي مع الديبارتمنتس الموجوده، اللي من خلالها انا العب دور واحد موجود بين الفريق الطبي العظيم اللي احنا نشتغل عليه هنا. فانه يقول لك هو عود من حزمه، ما انا ماني الحزمه كامله، فانه احنا نشتغل بشكل كولكتيفلي بطريقه معينه عشان نعطي المستفيد افضل خدمه.
أتمنى أني جاوبت. العافية، الله يسعدك أبد. ويعطيكم العافية جميعا على جهودكم المبذولة.
جزيل الشكر، شكرا لكم، شكرا لك أستاذ ماجد، شكرا لك دكتورة أمل. وفي عندنا تجربة احنا صنعناها عندنا هنا، تلقونها برا، اللي هو عندنا رجلين صناعية موجودة، تقدرون تجربون اللي هو المستفيد كيف يحس وهو يمشي في الطرف الصناعي، فتلقونها برا في الملعب. وأبد حياكم الله، شكرا.
شكرا جزيلا للمتحدث الدكتور ماجد العتيبي، والأستاذ ضاري المبيض، والدكتورة مها أو الدكتورة أمل طناب. والآن راح يكون عندنا بريك إلى الساعة 1 and we will resume. وفي طبعا الضيافة الخارجية اللانش بريك and I hope guys you enjoy. Thank you very much. السلام عليكم. Okay. Hello everyone and welcome back and hope that you enjoyed your lunch break and for the next we will start to introduce our third presenter. He is a consultant physical medicine and rehabilitation amputee rehabilitation medicine. He will introduce the advancing amputee rehabilitation in Saudi Arabia, overcoming challenges in sizing opportunities. Please give a warm welcome to our presenter, Dr. Faiz Al-Shahri.
Thank you so much. Thank you so much. And good afternoon, everybody. The pointer is here. Okay, perfect. Okay. So, good afternoon, everybody. Today we will go through the amputation rehabilitation in Saudi Arabia. We will discuss a couple of issues. Sorry, first of all, to keep you waiting for the last 5 minutes, but it was with Mr. Dari visiting the workshop, so I apologize for everybody for the delay. Starting with amputee rehabilitation in Saudi Arabia. Before I start, I'll just give a quick disclosure. Yes. So nothing to disclose except that I'm biased toward the governmental agencies since I'm the medical director of the largest Ministry of Health program for the amputation rehabilitation at the King Fahd Medical City. However, there is no other disclosure. So before we start, I'll just ask everybody let me give a number. So how many limb amputations do you think we do have here in Saudi Arabia? In terms of number, I will give a number, okay, or like a common number. Maybe you heard it in a couple of, in the media. So like one amputation in every 30 seconds. Do you believe this is correct? Or so whoever think this is right can raise his hand. Like 30 limb amputation every year. Every 30 seconds. كل 30 ثانية one limb amputation. Is that correct? Do you think is this right for Saudi Arabia? Okay, incorrect. So incorrect. How many voting for non-correct answer? Okay, everybody. Okay, so we are not going to go through the prevalence of amputations as there will be like another session by tomorrow. However, I would share like couple before we I would share the outlines and then I will give you a hint about that number too. So we are going to talk about limb amputation prevalence just briefly because there will be a separate session by tomorrow. Then we'll go like exploring the current landscape for the amputee rehabilitation in Saudi. Can you hear me clearly? No, we'll give the number. This is at the end, actually at the end of the presentation. So, but feel free to interrupt if you have any question or like comment. So we'll go through the landscape of amputee rehabilitation in Saudi Arabia, which is still vague. However, we'll like share some of the insight that we have locally. After that, we'll talk about the importance of amputee rehabilitation, the comprehensive, the ISF model, whatever you can call it. But I mean, having a comprehensive rehabilitation is very important for the amputee care. Then we'll speak about how to measure some outcomes. There will be a separate session detailing that part. However, we'll give an overview, not only for the specific functional measures, we'll go toward even that measure the stage after the rehabilitation, also the follow-ups, some like organizational based measures, but it's not in depth again. It's going to be like a very brief overview. After that, we'll go through the most important part, the challenges in amputee rehabilitation. I would share like about 12 challenges that we have, but we have definitely more. And the opportunities for each challenge, there is an opportunity that we can work on and improve. And we'll end up with a couple of recommendations at the end. So, starting by the statistics. So this is a worldwide statistics, the one you might heard about it, one amputation every like 30 seconds. But this is, to be honest, this is a data that has been shared by United Nations in about 2005. And for that data, again, it's like an estimate, it's not like real data. And for that, there is like about 1 million limb amputation globally every year. With that perspective, what we have like as an accurate data, we do have in United States of America, they do have like more accurate data because they do have a lot of registries. So they have almost 300 to 500 amputations every day, and almost like 185,000 annually. And this is like an accurate data. What we have in Saudi, this is one of the statistics. So we, in the past, there was a collection of data that is reported by MOH, Ministry of Health, for a couple of centers that were reporting. You can see here, Medina Munawwara, they are reporting more. So again, these data are not accurate, but this is what is publicly available in terms of data for limb amputation. This is 2014. And again, this data actually, it doesn't include actually those who are not within the, like for example, medical cities like King Saudi Medical City, King Fahd Medical City, other cities, they are not included. And you can see here, the most common is started to be these secondary to diabetes and peripheral vascular disease, which is understandable. And again, 2016, I believe this is the latest data we have that calculate also some of the cumulative data for the, again, MOH. It's only a snapshot for the MOH. We don't have data, unfortunately. Again, the details of the prevalence will be discussed tomorrow in the other session. Now, what is the current landscape of amputee rehabilitation in Saudi Arabia? Before that, let's talk about the importance of amputation rehabilitation, why it's important, why we do have to have an amputee rehabilitation service, like comprehensive service in Saudi Arabia or worldwide. So definitely effective rehabilitation is not only aid the physical recovery, which is important, but also go beyond that to reintegrate the person with limb amputation to go for overall the quality of life that those patients or those group of people deserve. So what are the outcomes that are expected to that the amputee rehabilitation provide to those patients? It will speed up the recovery. It will address not only the physical issues, the mobility. No, it will go as maybe the Majid, he was here in the morning, he was talking about the challenges. The psychological challenge is very important for all patients with the limb amputation. Not only those who have an acquired amputations or secondary to trauma or even diabetes or other factors. This is also important for those people with limb difference, which we'll talk more about their needs in tomorrow discussion for the amputation limb difference in pediatrics. So the other thing also which is important is to ensure the effective maintenance of prosthetics. This is, if you have a program, if you have a comprehensive service, definitely you will end up with appropriate care that's not only providing of prostheses, also the appropriate care in terms of providing the maintenance, the long-term care that the patient deserves. And also sometimes patient will not be a candidate for prosthesis. So that is another discussion. Of course, the reintegration for society is very important, and giving or providing a long-term care for those patients. Now, what do we have in Saudi? It's primarily like publicly funded service, and most of the load, most of the patients are treated or provided the services in a governmentally funded organizations. Unfortunately, we have very, very, very limited inpatient. I can think about two facilities that can give an inpatient rehabilitation for person with limb amputations. Now, back in history, we do have the first prosthetic center, which established like 1974, and that was the first center. In the 80s, there were a couple of centers, not only for MOH centers, and also a couple of centers for the other governmental organizations, like military hospitals, like all academic institutes, because they do some of the academic institutes and some other governmental, like King Faisal Specialist Hospital, and but we have like about 17, give or take, centers that or workshops that provide the services within Ministry of Health, either clusters, medical cities, or even within hospitals. This is a rough number. And again, as I've mentioned, the other governmental facility, this is the 2018 study that Mr. Dari today morning have pointed out, and it was like a part of business study evaluating the services available, and they ended up for the BIF, and it was for the investment purposes, and it was like about 16 different workshops that were enrolled in that evaluation, and they have like an estimate that we have about like 1,000 procedures annually, which again I think it's not representative for all, but this is based on the accurate data that we have for that study. Now, what other organization? Is it only the public sector? Is it only the or do we have like other options in terms of services? So we do have the private sector. However, there is very, very minor contribution, in my opinion, from the private sector. We don't have like much data, but we know that we have very limited, for a fact, limited contribution. However, the non-profit sector we do have, and this is the other issue with the non-profit sector, because we have the either governmental, either private sector, or the non-profit. The non-profit sector, out of almost 5,000 plus organizations in the National Center for Non-Profit Sector, only 38 are providing a services for people with limb disabilities, with disability in general, and out of those 3, non-profit organizations are providing a services for amputee rehabilitation, specific services, or at least they provide some services. One of them is the one was represented by Mr. Majid today, and more importantly, we do have Ífáء. Ífáء is counted also as a non-profit sector. We have only 4, almost, in the non-profit sector. By the way, the non-profit organization, there is a classification. So in addition to this 5,000 organization, we do have like about 3,500 organizations, but in total, and they are working with the National Center for non-profit sector under the umbrella of each organization, but they have like Ífáء. In terms of funding, so we knew that the government are the primary funding for the services in Saudi. In addition to that, we have also services that have been given or done outside Saudi, and this is one example. I believe Mr. Dari have highlighted this contribution which is an excellent contribution beyond Saudi Arabia for the amputee rehabilitation for the King Salman Humanitarian Aid and Relief Center. Not only for amputations, also they are serving the other like medical needs, and this is very important to highlight too. So the government are the only participating, I would say, apart from like other limited like initiatives or organizations. So why what is the importance of the rehabilitation program? I believe Dr. Amal today, she gave some background about the appropriate rehabilitation, the involvement of appropriate like a rehabilitation team. We'll go through, yes. Why, yes. So again, this is to highlight the importance of the comprehensive rehabilitation, because we have a team that will coordinate the whole care of the patient and provide the appropriate service in a holistic manner that enhance the function and improve the the function recovery. Let's go to the amputee rehabilitation team. How many members do you think that we can include for the amputation rehabilitation team? Even like ambulatory team or inpatient or whatever, like numbers? 5? Yes, yes, of course. So we do have the core team and we do have the supportive team. The core team has to include, this is for the amputee rehabilitation team. So then we'll talk about the extension of the services that can be provided and the whole, if you ask me about the discipline that they have to be included for the for the limb amputation, it's even wider. If we went through even the preventive measures, the surgical team, medical team, which we will include or discuss about later. So primarily we have the physician, the physical medicine rehabilitation physician, and also we have the CPOs, the prosthetic specialist, physical therapist with experience in amputee rehabilitation, occupational therapist with again experience in amputee rehabilitation and prosthetic rehabilitation. Rehabilitation nurses role is very important, especially for the inpatient services. And the team can be expanded according to the needs of the patient, and we have sometimes consulting professionals. So sometimes not all the discipline are included, or the team are limited for a couple of disciplines. But in an inpatient setting, wound care specialist is very important. Dietitian, pharmacist, psychologist, very, very important role, especially for the acute injuries. Podiatrist, or chiropodist, whatever, or chiropodist, whatever you call it, but this is very important role to be included in amputee rehabilitation team or to have an access to. Now, recreational therapy is very important, not only recreational, also the other dimension of the recreation, whenever is appropriate and available, and the access to other services like medical, surgical, and I told you it depends on the organization. We don't have to have this for all organizations, but the core team are core team. But the remaining part, it depends on how the services are running, how are the scale of the services provided, but definitely the patient has to have an access to the appropriate team member. Now, the coordination is very important. So having a team is critical, but if we have a team without a coordination, it's a useless team. So we have to have appropriate coordination between the team members, and sometimes even with the patient, okay, if you provide a patient with appropriate management in the acute or subacute level, the patient has to have an access. If the patient will be discharged or complete the rehabilitation process, he has the right to have an access back to the rehabilitation service. So this is common in the community-based practices where the patient have no like frequent like or primary physician that who is following the patient in or service within amputee rehabilitation services. Some patients, they have to have at least that follow-up coordination to like ease the long-term care that the patient needs. Now, just to highlight, I didn't add that additional like team members, child life therapist, very important role. Also the assistive technologist, by the way, it's very important, especially for patients with bilateral amputations or like very specific needs. And we do have it in our center for complex cases. Now we will move to the outcome measures, or how to measure the outcomes for the prosthetic rehabilitation services or the amputee rehabilitation. Okay, what is the goal of that outcome measure? It is very important to improve and to ensure the quality of life for those patients and quality of care that we need to provide for them. So some of these outcomes are functional outcomes. Some are related to quality of lives. You can go with also some with regard to the psychological outcomes. The prosthetic use, how frequent we, or the satisfaction also is very important. The follow-up, and also there is a measures can measure the organization itself. But these are generally the dimensions or the domains that outcome measures has to cover for amputee rehabilitation services. Definitely the reintegration to society, that is also very important. Now, these are a couple of approved outcome measures for lower limb amputees and commonly used. It can start with a very simple like outcome measures as a range of motion, and it can extend beyond to the very detailed assessment or targeting the quality of life aspects. We don't need to use all of them. Each center, each discipline has to select the appropriate outcome measures and make sure that is done and in appropriate manner, like in terms of continuity of using this outcome measure. Because if we didn't use it, if we did it for some patients, and we didn't include all patients, there will be a gap. If we did it but we didn't continue to use it for patients appropriately, that will not be reflected. It's not an outcome measure anymore. For upper limbs, we do have these couple of outcome measures. Again, there will be a detailed session for the outcome measures. But these, again, can be simple, very simple, to the more detailed, I would say, outcome measures. Now, what are the challenges? I told you we have, I will share with you about 12 challenges that we have in the amputee rehabilitation care. However, challenges can be more and can be variable according to the service, according to the also the organizations, the discipline, and the patient also him or herself. Now, starting by the access to care. This is the most important and the difficult challenge. Today we had a patient in the morning who talked about patient need and the access to the care, which unfortunately a concern for patients. And not only the access to the services, even the continued care after the initial or rehabilitation services that the patient, because it's a lifelong care. So this is, but before that, some of those patients will receive the access. There was one study in Saudi that investigated the access to care. Some of those patients, they received the first assessment 1 year after the amputation, unfortunately. So, or they have an access at that point. The economic factor is very, very important challenge. And it is a barrier, especially because of the high cost of the prosthetic equipment or components, and also the cost of the specialized team, and also the services, the equipment that we need to have for the amputee rehabilitation. So the cost sometimes is a barrier for also establishing such services, unfortunately. The other thing also, the insurance limitations. Unfortunately, the insurance is a big barrier for the prosthetic and rehabilitation services, and we don't have like a clear, I believe there will be like in the near future some sort of review. However, unfortunately, we don't have like, even in terms of numbers, we don't have like clear numbers. And if you go for the insurance policy, section 23, you will find that those services are excluded, unfortunately, from rehabilitation. However, I have discussion today morning about some of the one of the stakeholders about some of issues. However, still that problem is existing problem, the insurance, and whenever those restrictions, because unfortunately these restrictions are primarily for people with limb amputation, but it's not like some other like services, other like intervention, medical surgical intervention are included, though it's like less needed for the patient as opposed to a prosthetic or amputee rehabilitation, comprehensive rehabilitation services. Now, these are 3 out of 12. We have the transitional care, especially in the acute services or acute setting. We have an issue with those patients who have like a chronic or major acute comorbid condition that impact the prosthetic intervention. So those patients, they need like to receive appropriate treatment, appropriate comprehensive evaluation. The role of BMNR physician is very important in this stage, and to limit the gap. If there is a like opportunity to do a pre-amputation assessment, that is the most appropriate like intervention, but not all like amputation elective. Some of them or most of them unfortunately will be either critically elective or as emergency surgery. Sorry. So the lack of awareness is another important factor, and we talked about today during the panel discussion. Not only the awareness of the organizations, stakeholders, also the awareness among the medical community about the importance of amputee rehabilitation. In addition to that, there is an issue with the compliance, the adherence to or compliance to rehabilitation interventions, not only because of patient compliance during like like refusing or having an issue with getting the appropriate service or not complying wherever like a patient is needed to follow. The issues also sometimes with the difficulties that the patient, sometimes because of their social, some other factors that impact their ability to comply to the treatment plan. So we have to explore these limitations when we discuss with the patient and have the appropriate plan. So sometimes that is the role of comprehensive amputee rehabilitation, to select the most appropriate intervention for the patient. Sometimes you might downgrade the intervention because of that compliance issue or the specific demand of the patient, or specific or the other limitation that the patient is having. The complex care needed for the patients is very important, and this is already highlighted this point. In addition to that, the disciplinary coordination, because having the team is important, but the most important part is to have a coordination between those team members. Otherwise, you will not end with appropriate or proposed outcomes. Okay. The limitation in terms of staff, or like specialized or medical staff specialized in rehabilitation and amputee rehabilitation, this is another barrier. And I disagree with the comment during the today discussion in the morning. No, we lack a lot of, like in terms of the trained discipline that serve those patients. Another challenge is the resource allocation. So, and this is like from the, if you zoom out in terms at the level of the executive level or the decision makers, they do have an issues with allocating the services, which is understandable. Sometimes, but amputee rehabilitation is very important and critical, and has to have the priority in terms of planning the needs of those patients, because sometimes they have like a short term like plans and they don't see the big picture. Unfortunately, this is our role, to advocate for the appropriate rehabilitation care. Long-term support, this is another challenge with amputee population, and we talk about that at the beginning. And this is going to continue as a important challenge. The technology adaptation, not only for the patient, sometimes it's challenging. When we have not only because it's easy for, like, I mean, for discipline to have like a certain training programs to keep up with these advances. And this is very important and critical for all organizations. But also sometimes patients, they request something because it's there or it's under like investigation. They request that intervention to be their primary, like certain procedures. I need that one, but doesn't match their needs. It doesn't match their functional level, or it's not like available, or still at the research stage, or it's not appropriate. So these are another issue with the technology, but we have to keep up with that technology. Now, I've told you like we have challenges, and like 12 challenges. However, we have for each challenges I can see like 12 opportunities. But we'll talk about like briefly, like in some domains, how we can like work on improving the rehabilitation services for amputee, for persons with or people with limb amputation. The most important part is the policy decision. So we have to advocate for policy changes. We talk about insurance. We talk about, organization not giving the priorities for the amputee rehabilitations. This is what, the most important. I see it as an opportunity for us to push and advocate for the limb amputation or amputee rehabilitation. But we need also, there is a chance for improvement. However, we need, like, this is an open venue for us to work on establishing a local guidelines to have proposing the appropriate intervention. So this is our part in terms of advocacy, and that is not easy. It's easy said that done, but it's very important. The other part also, the role of integrated care teams, having multidisciplinary collaboration, because we have the team and like most organizations or centers, but we have to work together. This is a chance for everybody, for all organizations. When you have like a discipline that they are working, however, they are working like individually. I believe this is an opportunity for us for those organizations to further work on that part. Because enhancing collaboration between rehabilitation profession, and this is not only, by the way, limited to the rehabilitation staff. this is extended to the other disciplines. When I talked about the arrangement or coordination with also medical surgical teams, with also not only within the healthcare, also with engaging the other components of healthcare systems. Okay. So there are no much centers we do have like locally. So this is an opportunity to have. So it's an area for investment to have multiple specialized centers for those people with limb amputation. In addition to that, there is a chance or opportunity for the telehealth services, which is important. It can be integrated whenever appropriate for the patient with limb amputation. This is another aspect. In terms of local and global collaboration, this is one of the local collaboration between governmental and non-profit sector here in this event. And we need more. This is a chance to have more and more collaboration on that part. Sorry. Conferences, workshops, training is very critical and important. Now back to the outcome measures. When you have an outcome, or you have, if you have work and you would like to have an appropriate quality, you have to have an appropriate outcome measures to use. So we highlighted some of the outcome measures that has to be used. However, it is for each organization to select the appropriate and match their needs. And this is another opportunity. Education and professional development. So we do have training programs for physicians for some of allied health, but we need to expand that to include also the all discipline working in amputee rehabilitations, and specialized training can be developed targeting those disciplines to make sure that they practice and the most appropriate care and provide the most appropriate care. The research is very important opportunity. We don't have data, so this is an area for improvement. We can use that and have a lot of interventions, targeting, collecting the appropriate details for the questions that I will answer at the end of the presentation. But we need data. We need a lot of research, because our people are different. Our people, different terms even of their needs. Some of the specifications for those patients are different, and we have to adopt our for the need of those patients. Now, I will have a couple of recommendations, actually 5 recommendations by the end of this talk. After these challenges and opportunities, if we need to, we need to have a local registry for the limb amputation. This is very important. I told you the example of US. It's not easy to have a registry. It has to be, but we do have it here in Saudi. I mean, there is a very advanced countries who doesn't have registry in their countries. However, we have the cancer registry. We do have also the diabetic registry, because there was a need. So we need to advocate for that, and this is my primary recommendation. The other one, also having a comprehensive rehabilitation programs that employs the multidisciplinary approach, multidisciplinary or even interdisciplinary. That is crucial to improve the success for the people with limb amputation rehabilitation. Advocating for policies and that support better funding, because we have spoke about the limitations with regard to the funding in non-governmental like organizations. So the funding is very important. Allocating the appropriate resources. Insurance, there is transformation even in the insurance nowadays, and hopefully that can be further improved to accommodate those patients. Specialized training is very important, as I mentioned, and essential to enhance their skills and knowledge and improve that this will be reflected on patients' quality of life. And the last recommendation, the engagement. This is one venue for the engagement of all, like governmental, non-governmental, private, non-profit, to expand the outreach and the resources availability, particularly for those like who have very limited access to the specialized care. Before I conclude, I'll ask the same question, and I might ask even more. So, how many limb amputation performed locally? How many patients like receive intensive or like comprehensive, rehabilitation care? How many patients like return back to his life after amputation in Saudi? The truthful, the unfortunate answer, we don't know. Thank you so much. Thank you. يعطيكم العافية. الله يعافيكم. Thank you so much. Okay.
Thank you, Dr. Faiz Al-Shahri, for the fascinating talk, and we really appreciate the depth and clarity you talk about the advance of the amputee rehabilitation in Saudi Arabia. And for now, we would like to I would like to introduce our next presenter, who is going to talk about the insight into physiotherapy roles and in pre or post prosthetic fitting stages for major lower limb amputation. Please welcome our presenter, Mr. Abdullah Al-Abdullah, to the stage.
السلام عليكم. كان الصوت شوي قوي. Hello everybody. I am Abdullah Al-Abdullah, senior physiotherapist specialized in amputation and prosthetic rehabilitation. Today we're going to be having an insight into physiotherapy role in pre and post prosthetic fitting phases for major lower limb amputation surface. These are the outlines of this session. At the beginning, we are going to have an introduction and background about amputation rehabilitation. Then we are going to explore the role of physiotherapy in amputee rehabilitation, including clinical assessment, skills, and knowledge required by physiotherapists working with amputees. Examples of pre and post-prosthetic physical therapy interventions. We will also have a look at gait analysis and gait deviations because of body biomechanics and gait training, and finally take-home message. So, what is amputation rehabilitation? Dr. Amal and Dr. Faiz, mashallah, they covered a lot of points about amputation rehabilitation. It's actually a continuous and sequential process, starts from the amputation decision and proceed throughout patient life. It's not stopped when the patient discharged. It's proceed throughout the patient life. It involves different rehabilitation specialties to manage all aspects of patient life, including physical and mental and emotional and social parts. As we can see in the picture here, we can see the patient in the center, and he's the main person in rehabilitation. He's the core one. He's the one who receives the service. As Dr. Majid Al-Ataibi mentioned in his inspirational speech, if patient is motivated and patient is willing to achieve something from rehabilitation, to be able to walk again, to participate in the community, the chance of successful rehabilitation is higher. So he's the main one in the rehabilitation team. And he's surrounded by other specialties, physician and physiotherapist, occupational therapist, and dietitian, and social worker, a prosthetist and orthotist, and occupational therapist. All these specialties and psychologists are very, very important to work with amputees. Okay, these are the amputation rehabilitation phases, where the physiotherapist going with the patient in each stage, and even after discharge. So the physiotherapist has the closest relationship with the patient throughout the rehabilitation services. We get the first one, which is pre-amputation phase, and it starts from the amputation decision until the patient entered to operation room. We get the next one, which is post-amputation phase, and it's from the operation room until the patient discharged from the inpatient. And we get also pre-prosthetic and post-prosthetic, and these phases are between prosthetic fitting. And finally, we get lifelong care, where patient comes for follow-up sessions, for maintenance, or for check the residual lump or issues with the prosthesis. Okay, what is the role of physiotherapist within the rehabilitation team? The first rule is the physiotherapist plays a really important role in regaining and optimizing lower limb amputees' mobility, independency, and quality of life, and reintegration into normal life. The physiotherapist have a really important role in performing continuous assessment of goals, needs, and abilities throughout all rehabilitation phases to tailor a realistic and agreed treatment plan, then facilitate achieving the goals. Physiotherapist has a really, really important role in educating amputees new strategies and skills to adapt with amputation and to do things by and for themselves. Physiotherapist has a really, really important role in preventing post-amputation complications and preserve patient static shape and functionality as much as possible. Clinical assessment. Physiotherapist, as Dr. Faiz mentioned, is a part of multidisciplinary team that has been involved in the assessment. And the clinical assessment, according to the British Association of Chartered Physiotherapy in Amputee Rehabilitation, they produce an evidence-based guideline that physiotherapist has to be involved in clinical assessment, and they recommend the following. Clinical assessment should gain an understanding about patient journey, what happened, what has patient been through, and their current situation. The clinical assessment also need to carefully assess previous functionality of the patient and if there were any musculoskeletal or neurological dysfunction that influence rehabilitation outcomes, like congenital deformities or stroke or any other diseases. The clinical assessment should also contain a detailed subjective and objective data and assessment, as well as treatment plan to ensure accurate and realistic goal. Sorry, I have to go back. Okay. Assessment also should widen to apply a holistic approach and include lower limb and trunk and upper limb, not only considering the residual limb. And this point means we need to deal with the patient as a whole, not as like separate part of the body. So we need to do a holistic and wide our scope in assessment. The assessment of pain intensity and interference with function should be separately assessed for each pain type. There are a lot of pain types like phantom pain, neuropathic pain, residual limb pain. All this pain, we need to deal with them separately and identify the location and using standardized tools like pain intensity outcome measure. The final point here is patient and family should be involved in tailoring treatment plan and then deciding realistic rehabilitation goals. As we mentioned, patient is the core of the rehabilitation, and he needs to be involved in decision making during the rehabilitation and the rehabilitation outcome. Frequent assessment in all rehabilitation stages is also required to help understanding recovery and guide any revision in rehabilitation goals. Frequent assessment in each rehabilitation phase by using outcome measures, and the outcome measures need to be valid and reliable and responsive to measure the context they are identified to measure, so it's valid and reliable. The final goal and aim of assessment should improve the quality of life of patients as well as optimal independence in daily activities, whether with the prosthesis or not. We need to know that not most of amputees will end up with prosthesis. Some of them might have any problems related to the stump, to the residual limb, so they cannot use the prosthesis, either because of neuroma or any sort of problems that doesn't enable them to use the prosthesis. So we need to improve the overall quality of life. Okay, these are the examples of subjective data that may include in the clinical assessment form. The date and level of amputation, reason of amputation, ulcer or gangrene or lower limb ischemia, and etc. Comorbidities, and we really need to mention the comorbidities in clinical assessment because comorbidities may have influence into outcome measures, into outcome of the rehabilitation. Social history, access to the home, and if there is family support or not, the income, all these things, we could guide the patient to access the appropriate service when we identify the issue. The lifestyle of the patient, we need to have a clue about patient lifestyle before the amputation. Was the patient active or not? Is he obese or having smoking or their attitude to exercise? All these things will help us to identify a realistic goal for the patient. Pre-amputation mobility status, like how active was the patient before the amputation. We need to really take the history of the patient and take this point into consideration. Post-amputation mobility status and its status from amputation surgery, how the patient transferring, bed mobility and type of assistive device used after the amputation. The functional level in terms of self-caring, bathing, carrying objects, and also we could guide patients to access the service, like to go with occupational therapist, to have the appropriate intervention if there is any limitation in these activities. For prosthetic user who came for maintenance, we could take the prosthetic history of the patient, including delivery date, type of socket fitted with, ability of donning and doffing, the maintenance if patient has been through maintenance, the pattern of use, how long the patient used the prosthesis, and how far the patient can walk. All these things will give us a clue how to decide the best outcome for patients, and if we need to change any prosthetic component for the patient, and if we are doing maintenance for the prosthesis. Psychological status, there should be an assessment for psychological status, and this is really, really important because the chance of depression and anxiety and mental issues are higher with lower limb amputation in acute stages. And so the presence of psychological issues might limit our progress in rehabilitation, so we need to help patients to access the appropriate service once we identify the issue. These are the examination. We need to examine the residual limb in terms of the wound healing status, what type of dressing, if there is edema, if there is how is the shape of the residual limb, joint range and contracture presence, and muscle strength. All these areas we need to examine in the residual limb, so we can decide the treatment plan. We shouldn't just focus on the residual limb. We need also to examine the contralateral limb as an important part during pre and post prosthetic rehabilitation, because patient is going to stand on this on the sound leg. So we need to check if there is problem in the terms of the muscle power, in terms of the joint range, wound existence, and it's for amputee because of vascular or diabetes, very great chance to have wound in the sound leg. If there is any pain or edema, deformities, all these things need to be checked. We need also to have a measurement of pain intensity, and there are a lot of types of pain, and as I mentioned earlier, we need to measure them. Trunk and balance, gait and function with prosthesis. All these things we'll mention in the coming slide, inshallah. Outcome measures. In the clinical assessments, we need to have and use outcome measures that is valid and reliable for the patient. And the literature is full of outcome measures. And there is like variety of uses. And the reason why I included these outcome measures in this table is because it's mentioned in two guidelines. The first one is British Association of Chartered Physiotherapists toolkit for outcome measures, and the other one is Veteran Affairs Department of Defense in USA guidelines. They agreed on these outcome measures to be used clinically, and the first one is Amputee Mobility Predictor, or AMP Pro or AMP No Pro, and the AMP No Pro stands for No Prosthesis. It is useful outcome measures to measure the activity level. It takes up to 15 minutes, and the normal it has 20 items, and the score is out of 43. And based on the results of these outcome measures, we could identify the activity level of patients, and based on that, we can decide on the prosthetic component for the patient. We got also timed up and go test, or tag test. It measures the functional mobility of the patient and the risk of fall, and it takes up to 5 minutes, and the range is from 16 to 41. There are a lot of factors that influence on this result, including the level of amputation, the age, and how heavy is the prosthesis. All these things have an influence in this outcome measure, in this result. L-test is an outcome measure, and it's modified outcome measures from TAG test. It measures functional mobility and risk of fall. It takes up to 5 minutes, and the results range between 17 to 57 seconds. We get also Berg balance test, and Berg balance test is widely used for neurological issues. It also can be used for amputees, and it takes up to 15 minutes. It has 14 items, and a score is out of 56. And the cutoff score for amputees is 45. When the patient score less than 45, it means the patient is at risk of fall. The final outcome measure here we got, a 2-minute walking test. It measures the walking ability and endurance of the patient. It takes up to 5 minutes, and the normative reference data between 26 to 141 meter for the patient. What are the knowledge and skills required from physiotherapists working with amputees? This is a really, really important slide for physiotherapists. The first point is the physiotherapist should have a good communication and pattern with rehabilitation team. As Dr. Faiz mentioned in his speech, we need to have coordination and communication skills between the team of rehabilitation, so the patient can access to the surface easily, so we can refer patient from physiotherapy to the referring physician or to a prosthetist for adjustment or something like that with the prosthesis. Physiotherapists should have a good understanding about prosthetic component available locally with their functions and limitation. This is very important point. The physiotherapists need to understand what's the function of the prosthesis. They need to have this knowledge. For example, manual locking knee is not allowing swing phase, flexion during swing phase, so they not expect the patient to walk with the manual locking knee with a knee flexion and doing swing during swing phase. Physiotherapists should contribute to prosthetic provision decision because he's the closest person to the patient, so he has understanding about the level of activity for the patient. He knows how active is the patient, so he could help in choosing appropriate prosthetic component for the patient. Physiotherapists should be aware of pressure tolerant and pressure sensitive area of residual limb in relation to prosthetic fitting. This is a really important point, and if we can see in the picture left side, there are pressure tolerant and pressure sensitive area in transtibial amputation, and when the physiotherapist understand these sensitive and tolerant area of the residual limb, he will be able to decide if the problem is from the socket or from if patient complain of pain during gait analysis or gait training, he can refer patient back to prosthetic department for adjustment. Physiotherapists should know the impact of prosthetic alignment and pressure distribution within the socket. This is really, really important point. I'm not going to talk about it more because our colleague Abdul Salam, inshallah, will talk about alignment in his lecture, inshallah. Physiotherapists should know how to use outcome measures related to amputation rehabilitation. As we mentioned in the previous slide, they need to know how to use them appropriately and where to use them. Physiotherapists should have an understanding about gait deviation and energy expenditure and their causes either by body biomechanics or prosthesis, and work to minimize these deviations. Inshallah, we will see in the coming slide the common gait deviations and because of body biomechanics. Finally, when identifying appropriate prosthesis component, patients should be trained gradually from basic prosthesis to advanced function, not to start immediately by C-leg. So like the one who learn how to drive, not to drive Mercedes immediately, so step by step. Okay, we will see now examples of pre and post-prosthetic physical therapy interventions. The first one is edema. And edema is accumulation of fluid around the residual limb. And the interventions is like wearing a stump shrinker or educating patient to position the residual limb in above heart level, bandaging by elastic bandage. And finally, we got pneumatic post-amputation mobility aid, which is temporary prosthesis used in the UK. I'll show you here in this slide. This is the pneumatic post-amputation mobility aid. It's an early walking aid consisting of pneumatic inflatable bag extending from groin below amputation residuum enclosed by frame cage. About 80% of UK physiotherapy departments are using this temporary prosthesis to help reducing edema and for gait education, gait training, and also to accelerate the rehabilitation process with after amputation. The one disadvantage for this temporary prosthesis is that it is used early, so from 5 to 10 days after the amputation, and it may cause open wound when it's applied in wrong way. So it needs a trained physiotherapist to apply it. Okay, what does evidence says about residual limb edema management? It is a multidisciplinary guidance produced by PACPAR for edema controlling, and this table is analyzing the result of systematic review of available studies. They found that rigid dressing has a strong evidence to control edema, and it's applied by surgeon or trained nurse, followed by temporary prosthesis, PAMAID, and shrinker and stump board. They have moderate evidence of controlling edema after amputation. And finally, we get figure of 8 elastic bandage. It has the weak result, and they justify that bandaging by elastic bandage might cause uneven distribution uneven distribution of pressure around the residual limb, so might not shape appropriate as needed, and also it might cause wound or any problems to the patient if it's applied by untrained specialist. Physiotherapist has really important role in controlling pain, and we got 3 types of pain after amputation. One is residual limb pain, and that pain comes from the residual limb because of neuropathic pain, or it could be because of neuroma, or because of the inflammation process following amputation surgery. We have also phantom pain, and it's the pain comes from the amputated part of the patient body. And finally, we get back pain. And there are a lot of interventions used with phantom pain, like desensitization techniques, stump handling or massage, educating self-management strategies for the patient. There are and how to control the pain, like wearing shrinkers or putting residual limb in free pain position. They might use some interventions like electrotherapy or mirror box, like in the picture here, to control the pain. إن شاء الله الدكتور راح يغطي مسألة الميرور بوكس إن شاء الله. Low back muscle strengthening exercise for low back pain. And this is the clinical guidelines produced by NHS for pain management. It was produced in 2009. There is 2 pathways, and it's for multidisciplinary team. And if we look to the blue side, we can see the role of physiotherapist. I don't know if it's clear from you, but they include TENS and thermal therapy, mirror box, and exercises, and destruction therapies, and desensitization techniques in the guidance. One of the important role of physiotherapists is preventing contracture after the amputation. And they educate patient how to maintain residual limb straight as applicable without using pillow under the knee joint for transtibial or under the thigh for transfemoral. Stretching and strengthening exercise, stretching for muscle that tend to shorten after the amputation, like hamstring muscle and iliopsoas muscle, hip abductor, and strengthening for quadriceps muscle and hip extensors and hip adductors. And while sitting in wheelchair, patient might use stump board, like in the picture here, underneath the knee with transtibial amputation to decrease the pressure going to the residual limb, so less fluid accumulation around the residual limb. Physiotherapist also has really important role in improving balance and managing risk of fall. And there should be posture assessment following prosthetic provision, because skeletal system makes compensation for imbalance caused by missing anatomy or restriction caused by prosthesis. And as we can see in the picture here in the right side, this is the compensation reaction of patient after transfemoral amputation. If we look to the midline, we can see that intact leg moved towards the amputated side. And if we look at pelvic level, the pelvic area in the amputated side is slightly raised, and the shoulder is slightly dropped, so like banana shape. If we look at the center of mass and relation into the body support, or the center of mass in relation to the amputation level, we can see in the first picture for normal person, it's at the center, but in transtibial amputation, it shifted higher, and for transfemoral, it goes higher and lateral towards intact side. For bilateral amputation, it goes up, and as much the level goes in unilateral amputation, as more the center of mass shifted higher and toward the intact side. Risk of fall is greater after amputation, especially during the 6 months after the amputation, and that because of phantom sensation, and the patient feels their limb still existed, and they stand on the limb and they fall down. And there are other factors that increase the risk of fall, like poor vision, home environment, confidence with the prosthesis, walking aid used if it's not used properly, medications, cardiovascular status, neurological status, balance, muscle power, and prosthesis. All these factors might increase the risk of fall. As physiotherapists, we need to help patients to address these risk factors by like balance and muscle power and prosthesis. We could use some physical therapy management, like strengthening core muscles and anti-gravity muscles, balance training, teaching how to use assistive device safely, and teach how to get off the floor in case of falling. But for other issues like poor vision, we could direct the patient to go to ophthalmologist for consultation and check the vision. Finally, we get muscular training, and muscular interventions include strengthening of anti-gravity muscles of lower limb, like gluteus muscle, iliopsoas muscle, and quadriceps, hamstring, and for both lower extremities, not only the amputated side. Strengthening exercise for shoulder girdle, especially biceps and triceps muscle, and both upper extremities, particularly in bilateral amputation, because they need it more in transferring. And strengthening upper extremity is very, very important for elderly amputees to enable them to use assistive device very well during gait training. Breathing exercise is also very important to increase chest expansion, because with using the prosthesis, there might be some energy expenditure that needs more oxygen from the patient, so we need to do breathing exercise, trunk control exercise, like bridging, pelvic tilting, and static sitting balance. Okay, let's move to the important point here, gait training. We need to note that as prosthesis introduced to the patient, physiotherapist at post-prosthetic fitting stage should reevaluate the patient's posture, gait, pattern, socket comfort, issues with the prosthesis, and functional limitations, then identify appropriate treatment plan and goal based on on them and based on the patient needs. Okay, how gait analysis should be performed? In some developed like prosthetic rehabilitation department, they got a gait analysis lab, and that is the process here. But if we don't have gait analysis lab, preferably patient should begin the gait analysis inside barrel bars with best feasibility of prosthesis and main lower limb joint. Patient should walk several minutes with rest breaks as needed. Patient should not use or minimize the assistive device use as safely as patient able. We need, as physiotherapists, to observe velocity and stability and consistency and symmetry of the steps, then determine abnormalities of prosthetic and intact limb through the gait cycle, from heel strike until the terminal swing. We need also to do evaluation for the step length, the stride length, and the step width. These are the common gait deviations following transfemoral and transtibial amputations because of body biomechanics. I'm not going to speak about prosthetic cause because Abdul Salam, inshallah, will talk about that in his lecture, inshallah. For transfemoral level, we get abducted prosthesis gait, and this is when patient walks with abducted prosthesis. It could be because of pain in groin or middle wall of the prosthesis, because of hip abductor contracture, because of fear or lack of confidence in transferring weight into a prosthesis. We got also lateral trunk bending and bending towards the prosthesis, and it could be because of short residual limb length, contracture in the hip abductors, pain in hip area of prosthetic side. It could be because of lack of balance and instability. It could be because of habit. For patients who use the short prosthesis for a long time, they got this habit. Circumduction gait, it's the gait when patient goes circle with the prosthesis during swing phase, and this is because of pain within the groin or mid wall of the prosthesis, weak of hip flexor, so the patient goes in abduction to compensate the weakness in the hip flexor. The absence also of the knee joint, the patient goes in circumduction gait. Finally, we get faulting gait, and the faulting gait is the gait when patient goes to plantar flexion in the sound leg to in the sound leg with the patient transferring the prosthesis in swing phase during the gait cycle, and that because of hip flexor weakness and different length between the prosthetic side and the sound leg. If we look at transtibial level, we got three gait deviations, possible gait deviations. and common gait deviations. The first one is knee fully extended at heel strike. This is very common gait deviations, and that because of the absence of quadriceps eccentric contracture during the heel. It could be because of pain within the socket. The next gait deviation is excessive knee flexion, which is the opposite to the first one. That because of flexion contracture in the hamstring, flexion contracture in the knee joint, also to compensate the ankle joint absence for if patient wearing such feet and going down slopes. Finally, we get stance face in the prosthesis. This is very, very common with amputee in transtibial level, and that because of discomfort and pain within the socket, fear or lack of confidence in the prosthesis, so patient doesn't shift weight into the prosthesis. That's it. Gait re-education. We need to educate patients once we identify the deviation, and the gait education should start inside parallel bars to provide safe environment for the patient. Gait training starts by weight shifting exercise, and also a pelvis rotation exercise to help patients during moving from stance phase to swing phase. We need also to educate patient about gait cycles and how to walk within the gait cycles from heel strike until the end of terminal swing. Gait training should minimize gait deviations, we mentioned in the previous slide, and promote energy efficiency and identify the reason of gait deviations to be able to solve this problem. If the issue because of weakness in the muscles, physiotherapist might strengthen the muscle to solve this problem. Physiotherapist might use temporary prosthesis, we mentioned earlier, PAMAID, for gait training even before the prosthesis to accelerate and to make patients get used with the prosthesis before getting the terminal prosthesis. Gait training starts with assisted device and progress until the patient achieves expected level of mobility. And gait training progress through walking with assistive device starts by walker, then crutches, and finally cane. And sometimes some patient doesn't need to use assistive device. Gait training might start ambulate inside indoor and outdoor and within the community. Gait training might involve going up and down stairs, walking slow, uneven trains. We need to train patients how to walk on these different surfaces, and we need to take into account to the safety of the patient. So if patient cannot walk in these surfaces because of age or muscle weakness, we cannot teach them to walk there. Energy cost. This chart shows the energy expenditure for amputees compared with non-amputees. We consider non-amputees as baseline. If we look at short transtibial, the energy expenditure is about 40% more than non-amputee. When patient walks 50 meters per minute, and for transfemoral level, it reaches up to 65% more than non-amputee when patient walks 40 meters per minute, which is a great number. So patients who have poor cardiac ejection fraction, we need to be careful about the energy cost with them and using prosthesis might cause a problem for these patients. Take-home message. Physiotherapist plays important roles within rehabilitation team in all rehabilitation phases after lower limb amputation. Clinical assessment should be holistic, involving patient and using valid as well as reliable outcome measures. There are some prosthetic knowledge required from physical therapists working with lower limb amputees, such as prosthetic components and their function and prosthetic alignment. Physiotherapist has a significant role in preventing or minimizing or controlling post-amputation complications. After prosthetic fitting, there might be gait deviation either because of body biomechanics or prosthesis, so physiotherapists and prosthetists should cooperate to deal with them for better outcomes. These are my references, and thank you for listening.
Thank you, Mr. Abdullah, for the comprehensive and enlightening presentation. And now we will start our discussion panel with Dr. Faiz al-Shahri and Mr. Abdullah. السلام عليكم.
السلام ورحمة الله.
أول شيء حابة أعرف عن نفسي. اسمي أروى يوسف أحمد، أخصائية أطراف صناعية وأجهزة مساعدة في قسم الأطراف الصناعية مركز الأمير سلطان التأهيل إيفاء. أولاً حابة أشكركم على وجودكم وجهودكم الفاضلة، خاصة أن كهيلث كير بروفيشنال شغلهم يشكرون عليه بالنسبة للي يقدمونه للمجتمع. وشكرا لجهودكم والبرزنتيشنز اللي عرضتوها اليوم. فحابة نبدأ. We want to also ask the audience to engage with us, and if you have any questions you want to ask them, we will start off first by asking my first question.
Sure.
So, I looked at your presentations previously, and I heard your presentation, Dr. Faiz.
Sure.
I have some questions. If you want to talk in English or in Arabic, as
It's
you
up to
wish.
It's okay, it's up to you.
And my first question is for you. What initiatives or programs do you believe could help address the social stigma faced by the amputees in Saudi Arabia?
Okay, so to answer this question, I do believe, I mean, first of all, we have to agree that this is an issue. I mean, the body shape issue, or the changes that the amputee or a person with limb amputation have after the amputation, this is a real issue, and we have to acknowledge or agree on that firstly. Second, I mean, the important rule is to start with education. So, educating the patient. So, if I look into this question, I would think about two interventions. One within the healthcare system in terms of like appropriate education of the patient about this concern, having the appropriate resources to address that within the healthcare system. Now, the other part is the initiative that can be done in terms of advocating the awareness for this. I mean, for the like, I mean, the changes that the patient have after the amputation. So definitely the role for the, I mean, I can see whatever like an initiative can be like within the any organization, but I think this is an area that can be also explored for the non-profit sector in terms of the advocacy for this part. I hope I answered your question to a certain extent.
Yeah,
okay. Oh,
thank you so much. And also, I want to highlight the in terms of the multidisciplinary team.
Yeah.
Is there any way that we can have them or to have a program for them? As you know, that not a lot of multidisciplinary team done inside the centers of healthcare centers, but sometimes we see the patients after, for example, after the surgery, the post-surgical. And do you think we have to have a discussion with the healthcare professional together inside the centers? Either for example, I see patients from outside of they come like after the post surgery, and I do the prosthesis for them, but I didn't engage in any of their surgical discussions, or because as a prosthetist I need to see the stump and how I could prescribe the prosthesis for them. In terms of the stump shape or the surgical technique that they have done, do you think we have to have programs for to educate the healthcare professionals for this?
Totally agree. It depends on the institution. So, and there have to be a pathway to address this problem. So not all centers have the privilege to have an acute services. It depends on the pathway and the structure of the institution, how much they are, like, I mean, the services provided, do they go toward the acute services, and do they have a link with the acute team? This is encouraged, definitely, but not all centers, they do have this available. But whenever, this is the ideal, like, I mean, care pathway. Even for those patients who are not included in terms of like or transitioning. That's why I added as a challenge in the presentation. Transitioning period is very important. However, it depends on the center at the end of the day. But having some like coordination for the care or follow up with the primary physician to own the care follow-up is very important in case that there is no continuity of transitioning for the care. This is what I recommend in this case.
For the next question, the access to the amputee rehabilitation services is kind of limited in the developing region in Saudi Arabia. So as many rehabilitation centers actually in the major cities like Damam, Riyadh and Jeddah, how can the rehabilitation services play a role in bridging the gap for patients in more isolated regions?
Okay, I've suggested a couple of interventions during the presentation. I mean, the non-profit like sector can bridge this gap, linkage or like coordination between the small facilities and also the primary centers would help. Also using the telemedicine like interventions would also assist, especially for those who are not capable of like accessing the care. So that is another intervention. But again, this is something will continue to be an issue till have like a better coordination.
We would like to give a chance for our audience to ask a question.
Yes. Hello. Is it working? It is. First of all, I would like to take this opportunity to sincerely thank all speakers, aside of the opening ceremony and all that protocol. I'm very glad to have to save this space for all of you to share your very valuable knowledge. And also, I would like to thank our own team for facilitating this very important event. My question to Dr. Faiz, you have mentioned that we know that there is a struggle, or we can call it a challenge, in terms of the insurance companies and what have you, regarding the coverage of the amputation and the services and the products. And you also have mentioned the solution, or could be the solution, through advocating and having like an effort that is well designed and structured by specialists to stand out for this challenge. As far as I know, this challenge is not going to be solved in the near future. It's not even in the radar of the healthcare system in the near future. So I really want to emphasize on deep diving into more solutions to really just have that voice raising more and more from the people that is really in the first need of that service, and from the specialist as service provider. So my question to you, what else can we do as a health provider, as people who do really want to make a change, an impact in that field? What can we do more in that challenge? Thank you.
Thank you so much. First of all, I totally agree with you in terms of the difficulties that we face with this prospect. What we can do, I mean, in terms of advocacy, this is one venue of advocacy and raising our voice to like, I mean, for the stakeholders, for the decision makers to provide their input. The other part, which I believe it's also feasible, that having like appropriate structure that I mean, where the team is all involved and providing the service in an appropriate manner, that can be as a starting point. Like for the health system, if they see this intervention and they see the outcomes that we provide as a team, as a comprehensive like rehabilitation team, that would save also the cost, that would impact also the outcomes for those patients. This is the part we can do. In addition to that, also we can do more like I mean, in terms of research and innovation, especially in terms of research, we can work on having like evaluation for local, like to establish a local data within this like framework that we practice, and we show and compare the evidence in terms of the outcomes for those as opposed to the traditional or the inappropriate care pathway. These are all other alternative strategies, but definitely without. That's why I put the first like intervention or is the I mean, the decision makers. Those and also they are the priority, to be honest, in terms of changing the pathway, to integrate the appropriate pathway for such patients. Thank you so much for the question.
Okay, thank you so much, Dr. Faiz.
Thank you.
Now we would like to move on to Mr. Abdullah. You are a PT, senior PT, and I have like different questions regarding the PT in Saudi Arabia. My first question to you is, what specific criteria do you use to assess whether an amputee is fully ready or eligible to fit a prosthesis or not?
This is a great question. You mean ready for prosthesis?
Yes.
Okay. I'm going to speak about our clinical experience in our clinical practice. We have like a checklist to check the important area of the important results for the patient before they referred to prosthetic center, including the muscle power in the lower limb or lower limb prosthesis. The muscle power in anti-gravity muscles has to be more than 3+. There is no neuroma or edema around the residual limb. There should be no limited pain or less pain in terms of phantom pain or any other kind of pain. Patient has to be able to at least stand up with a walker and transfer for at least 5 to 10 meters inside parallel bars. We get these points from service provided in the UK. They put this checklist to before referring to prosthetic center. It was really functional. We tried that in our clinical practice.
Excuse me, can I
yeah, sure.
intervene? First of all, thank you both for your interventions. It was a holistic approach of rehabilitation of an amputee. I would like to share an opinion from a professional from rehabilitation. I would like to involve more surgeons, orthopedic surgeons, to try to have a good collaboration with the physiatrists, because sometimes we receive amputees with very bad stamp, especially when it is in an emergency case. I understand we have to save the life of the patient, but when we have time, it's important to involve the physiatrist, because the physiatrist can give the ideal level of the amputation, and the future of the patient will be completely different, because when you receive a patient with an angle, Farabeuf angle, for example, not resected, it is hell for the patient to wear prosthesis. And if the surgeon collaborates more with the physiatrist, with rehabilitation team, I am sure that we will prevent these problems. The second thing, sometimes the surgeons would like to be very conservative when they amputate, which is not the right way. Sometimes a short stamp is much better than a longer stamp. It means the physiatrist has to give his opinion, and if there is a good collaboration between the surgeons and the physiatrists, I am sure that the patients will benefit more from good rehabilitation and good prosthesis. Second question, please, for another colleague, regarding the pneumatic prosthesis that you described in UK. I think it's a good prosthesis, but we have to be careful for the use of this prosthesis. It has to be under a good observation and good control from the physiatrist and the physiotherapist, because sometimes the pressure is over or not enough. It is very important to make sure to have a protocol to use this pneumatic prosthesis. Thank you.
You're welcome. Thank you so much. You can start, yeah.
Regarding to the pneumatic prosthesis I mentioned in my slides, there is guidance, full guidance about how to use this temporary prosthesis produced by the Chartered Physiotherapy for Amputee Rehabilitation Association. They said how much the pressure and how it's applied, but you are right. Not everyone can use this prosthesis. The physiotherapist should be trained before using this prosthesis with a patient. As I mentioned already, it might lead to other complications like opening the wound because it's applied within 5 days. So there might be some surgical revision for the patient because of this prosthesis. So the physiotherapist who is working or who is applying this intervention need to be trained enough before using it.
Yes, totally agree. I mean, with that comment, especially for the transitioning period post-surgery. That's why it's not like within an inpatient sitting or like there is a close monitoring on a daily basis. These like intervention would be difficult to be applied. That's why sometimes for those patients who will be received in a later stage, sometimes it's better because the wound healing will be better for them. So the other, going back to the same, so the first question about the concern with coordination, I've highlighted that during the presentation. It's very important to have collaboration with the surgeons from different, especially because for amputation it's not only orthopedic surgeons. Sometimes it depends on the center and institute who are involved within that center. Orthopedic are primary stakeholder or involved team, vascular surgery, general surgery. Sometimes also other surgeons will step in. That's why we see sometimes, unfortunately, different outcomes, and sometimes there will be issues with the surgical techniques. Having a pre-amputation evaluation, especially for elective cases, is always recommended whenever possible within the I do like couple of cases pre-amputations, but it's not always the case. Even sometimes the patient or the surgeon will have different opinion, but when we look into the function, we recommend totally different options. Sometimes it's difficult for the patient, and then after discussion and reinforcing the outcome, educating about the appropriate plan after the surgery, patient will go through smoothly and they will return back to community. But it's not, unfortunately, it's not always the case, and to be honest. Yeah.
And adding to what Dr. Mohammed said about the how they can the physiotherapists deal with the new innovations with the amputees. I would like to ask Mr. Abdullah about how the physiotherapists deal with the innovations in terms of a new knees, a new foot that we have. As you know, we as a prosthetist, we have to be trained with and take sessions for the use of and get certified to use the knees and foot. During the training after delivering the prosthesis, how can the physiotherapy deal with this patient if they see a new device that the patient have, and do they actually get trained, or how to keep up to date with the prosthetic devices?
Absolutely, physiotherapists need to be up to date about new innovations and new prosthetic components and new technologies. He needs to be also involved in training. And in our center, we applied the first C-leg in the southern region, and I were with our colleagues in the same training when they applied the C-leg. We need to be involved. We need to understand the function of the prosthesis. What is the possible function that prosthesis can provide for the patients? What's the limitations? All these things we need to understand before we give any gait training for this patient. So absolutely, we need to be trained and be up to date and read the articles and all materials that can help us to understand about these innovations before applying them.
Thank you very much for Dr. Faiz Al-Shuhri. And
thank you so much.
There is, let's take the last question from Dr. Amal.
Thank you very much for your presentations. It was really great. صراحة, I have a couple of questions, but I will try to minimize it. First, Mr. Abdullah, from your experience, do you prefer, I like the slide, the comparison between the shrinkage, figure of 8, and the others. From your experience, what do you prefer for the patients, the shrinkage or figure of 8? I think that shrinkage is easier, and figure of 8, if it's not applied right by the family, there is risks. What do you think?
Well, if you ask me from my clinical experience, it depends on the amputation levels. Shrinker is very good for transfemoral, as bandaging for transfemoral is embarrassing a little bit, because it's going to the sensitive areas, around the sensitive areas, so patient doesn't prefer it. So using shrinkers is much better for them. But if we look to the guidelines, they doesn't recommend figure of 8 bandaging. I actually using figure of 8 bandaging, but sometimes it might produce a negative result in terms of shaping the limb. It doesn't apply even pressure around the stumps. Sometimes the shape of stumps goes in the wrong way. So shrinkers is much better for me to use on edema reduction.
I know you work in Asir Hospital, which is a governmental hospital. We don't have the shrinkage. Do you have the shrinkage in your hospital?
There are some. There are some we use with the patients. Maybe it's.
لا احنا عندنا كلام بعدين. Sorry, another question regarding the PPAM. Do we have any local experience? هذا سؤال لكم both of you. I know you have an experience in UK, Dr. Faiz. I know in your fellowship, in your hospital, you have an experience with this. McMaster ما كنا نستعمله صراحة. What about local experience?
You're asking me, or Dr. Faiz? Okay, could you repeat your question again? I didn't hear it very well.
Any local experience in using the pneumatic?
Yeah, you're asking about pneumatic.
Yes.
Actually, there's no use, and we don't use this in our practice. I'm just talking about evidence. What does evidence says? I saw some of them when I was in the UK applying to the patients. But actually, most of these patients were not like fresh after amputation. They use it after 1 month. It's really good to accelerate the rehabilitation and to decrease the period until the patient gets the prosthesis. But as mentioned to Dr. In the previous question, it needs to be used carefully.
Exactly, I agree with that. If you don't have the acute facility that ensure the daily checking of the stump or like appropriate management, this intervention will be difficult to be applied. And the training of the provider as well.
Okay, thank you very much for
thank you so much.
There's one question. This is the last question. Please.
She already asked the same question that I want to ask. In addition for like this temporary prosthesis or the PAMate, do you think that this may cause a bad habit for the patient when they do the rehab? So when we fit the patient later with the definitive socket or definitive prosthesis, let's say, we for sure will use different components based on the patient's activity of level and patient desire. And you know this temporary prosthesis doesn't have components. So
Yes.
it's just a straight prosthesis. So this may make the patient like get used to this temporary prosthesis and not going with the definitive prosthesis, the new prosthesis. So do you think this may create bad habit for the patient when they use this temporary prosthesis?
Well, I don't have really clinical experience about that, but this is an area for research actually to find out if there is will make any like gait deviations after a patient using permanent prosthesis. I remember when I was doing my master's, I did a literature review about the benefit of using early mobility aids comparing with those who doesn't use them. Actually, the result was balanced. Some studies said that it accelerates the rehabilitation and it helps patients to get used with the prosthesis and to decrease the phantom pain because of embodiment of the prosthesis, decrease the edema. But in terms of gait deviations and creating gait deviations, no study mentioned that. So it's an area for research.
Yeah. Can I add also a comment for the same question? Yes. I believe the advantage that these interventions, the acute interventions, will give like 2 or 3 if I added the phantom pain. So the early like mobility, post-surgery, and also the other thing is like managing the edema or the swelling early on. So these are the 2 advantages of this intervention. So if you can have like different interventions that tackle 2 separate interventions, ensuring that early mobility is there, the appropriate management of edema is initiated, that would help out or be an alternative option for this intervention. And we have to know, we know all that the stump will continue to shrink and the patient will go through a long process, sometime continue for a couple of months, or some patients will go even 2 years of fluctuation till to reach the ideal or the most appropriate shape.
Thank you very much thank you for your effort, and thank you for the valuable information you gave us. And I would like to thank all the audience for engaging with us today. And we will take a short break for prayer. If you would like, for the male, there is a room on the end of the corridor, and there is a room for female on just behind this door. Thank you very much.
Thank you. شكرا يعطيكم العافية.
Assalamu alaikum. We have 2 minutes to start our next presenter. Assalamu alaikum. Okay. Okay. Thank you very much for our guest, and I hope that you have recharged yourself with a tea or coffee with this break. And for now, we will like to introduce our next presenter, who is going to speak about insight into prosthetic roles in the limb limb preparation prior and post-surgery. She is a senior prosthetist and orthotist. Please welcome CPO Zainab Al-Ghannam to the stage.
Hello, everyone. My part will be about an insight into prosthetist role and limb preparation prior and post-surgical. I will talk about the prosthetist role or the patient journey from a prosthetist perspective. I will cover our role prior to surgery, post-surgical, limb preparation for prosthetic use, impact of limb length, formulation of a treatment plan, functional level, outcome measure, importance of follow-up, and take-home message and next step in KSA. First of all, prior to surgery, one of our roles as a prosthetist is educating patients regarding contracture management. And this can be done either by prosthetist or other healthcare provider. Most importantly, we need to educate the patient on the things that they need to avoid or what not to do. For example, not sitting down on a wheelchair or bed with a crossed knee or flexed knee, not putting a pillow underneath their back, residual limb, or between their limbs. Also, we need to educate them regarding a prosthetic option and a prosthetic process. This is very important, especially for patients who are going through post-traumatic stress disorder. It could be motivational for them to know what they will go through and how to overcome it. Our role post-surgical, we will need to do compression therapy using different methods. For example, a shrinker sock, and this is the easiest one for patients because it's easy for them to don it and doff it. The other one is figure of 8 or ACE bandage. It needs to be applied correctly. Patients don't prefer it usually because they don't get how to do the figure of 8 in a correct way. The third option is elastic tubular stockinette, and this one also, some patients don't apply it in the correct way. The purposes of compression therapy is to shape the limb, promote healing, control volume fluctuation, and manage pain like phantom pain. The other option is modern post-operative prosthesis. Is slightly different than the one Abdullah talked about, the pneumonic. This one doesn't have the pneumonic style. It has just the rigid removable frame. It can be prefabricated or customized. The drawback of prefabricated one is minimal edema control, and it requires several sizes to be kept in stock. Versus the custom one, the drawback of it is time consuming because we will need to fabricate it A to Z in order to be customized to the patient's residual limb. The goals of it is facilitate healing, minimize pain, create functional residual limb, and protect incision line. So with the shrinker sock, we will not have this feature, which is protecting the incision line. Versus this one, because the frame is rigid, the incision line will be protected. Okay. After shaping the limb with the shrinker sock or the immediate post-operative prosthesis, and the limb is ready for prosthetic use, we will have two options. One of them is a preparatory prosthesis, and this one is not meant to be used forever. It will be made of a plastic like copolymer or polypropylene. Patients will use it for a certain period of time till the volume fluctuation gets reduced and the volume gets stable, close to stable. And then we will move to the definitive prosthesis. Will be laminated out of carbon fiber, and this one is also not meant to be used forever. If the patient loses weight or gained weight, it means it's time to replace it with a new prosthesis or with a new socket. Okay, when we are formulating the treatment plan for patients, we will be dealing with different limb lengths for transtibial, either long transtibial, mid-length, or short residual limb. They have advantages and disadvantages. Like the long transtibial residual limb, the advantages of it are better lever arm, less energy expenditure to operate the prosthesis, better control of prosthesis, and minimal distal padding. The disadvantages of this residual limb length, less room for components. So we will have limited option for prosthetic foot to put patients with long residual limb. Also, we might not have enough room to put inside and outside slider. The mid-length transtibial, the advantages of it is good distal padding, decent lever arm, better control of prosthesis, and room for most components. And we usually prefer this option, or this limb length. The short residual limb is the hardest to deal with because there are little surface for loading pressure areas, almost no lever arm, high energy expenditure, little control of a prosthesis, and little knee stability. Then, when we are formulating the treatment plan, after identifying the shape and the length of the residual limb, we will need to determine the style of socket, the kind of interface, the suspension mechanism, and the appropriate components. So for socket style, we have two main styles, either total surface bearing or patella tendon bearing. The total surface bearing is the cylindrical one versus the patella tendon bearing, the one that looks like a triangle. The indications for using the total surface bearing is when we are having sufficient soft tissue and sensitive skin. Is contraindicated for amputees with abnormal bony prominences, poor hygiene, or they are allergic to gel liner materials. The patella tendon bearing, it can be either supracandular or suprapatella, indicated for individuals with minimum length residual limb, minimal soft tissue, amputees who are living far from medical prosthetic care, poor hand dexterity, and poor hygiene. Is contraindicated for patients with very short residual limb. However, to overcome this point and using this style, we can use patella tendon bearing supracandular or suprapatella. As also contraindicated for patients who are having skin graft over pressure tolerant areas or fragile skin. So we need to upload the patella tendon, and if there is skin fragile at the patella tendon, it means we will not be able to load it. Also is contraindicated for bulbous residual limb. A skin interface, it can be either gel liner, foam insert, or flexible inner liner. The gel liner is indicated when we are using locking suspension mechanism or suction or vacuum suspension. Is contraindicated for people with poor hand dexterity because it will be made up of either silicone or gel, and it needs hand strength in order to don it and doff it. Also, is contraindicated for people with poor hygiene because it's required washing on a daily basis. Foam insert is indicated for individuals with anatomical, who are using anatomical suspension, impaired dexterity, blind amputees, and pediatric amputees. Pediatric because we can add padding at the distal end and remove those pads gradually as the residual limb is growing. It's contraindicated for individuals who are not using anatomical suspension. Flexible inner liner, personally I have never seen it used in KSA for transtibial amputees. As indicated for total surface bearing socket with gel liner, individual with bony prominences or area of sensitivity requiring additional relief. I've never seen it, however, as a good option because, as you know, many patients always come with the skin irritation from the edge of the carbon fiber of the socket. So with this option, we can conceal the trim lines, plus it will add the feature of adjustable socket. So we can remove it if the limb is swollen or put it back if the limb is shrinking. It's contraindicated for people who are using patella tendon bearing socket and pediatric. Suspension. We will suspend the socket into the residual limb using 4 different mechanisms, either pin locking, suction suspension, elevated vacuum, and anatomical. The pin lock is indicated for new amputees or first prosthesis, a blind amputee, because they will hear it when the pin is going inside and is engaging into the socket. And low activity, people with low activity level. Is contraindicated for bony distal residual limb. So if the patient has a prominent distal tibia with redundant tissue at the distal end, if we use this suspension mechanism, it could increase the distraction forces at the distal tibia. The second one is the section indicated for active amputees who don't have cognitive deficits, so they will be able to troubleshoot by adding socks. It's contraindicated for people with poor hand dexterity and poor hygiene. Elevated vacuum, this one also I've never seen it being used here in KSA. Is indicated for individuals with some to minor volume fluctuation expected, and there are gadget tolerance. Contraindicated for poor hand dexterity, poor hygiene, and poor gadget tolerance. As one of the best for active individuals because when they are using it, they feel the prosthesis is part of their body. They don't feel it as something just suspended to their residual limb. Anatomical is indicated for patella tendon bearing socket style, irregular limb shape or size, pediatric amputee, blind amputee, people with cognitive deficits. Contraindicated when the residual limb is bulbous or fleshy, when there are scarring or fragile skin over pressure tolerant areas like the patella tendon, and if the patient is has successful experience with other suspension mechanism. Auxiliary suspension, in addition to the above one that I was talking about, sometimes we need additional suspension mechanism, such as the suspension sleeve is required when we are using suction or elevated vacuum. However, it's optional for pin lock and anatomical suspension. We can use it just to increase rotational control. Is contraindication for poor hand dexterity, similar to liner. It will be made of gel or silicone, so it needs hand strength in order to don it and doff it. The other option is supracandular cuff or joint and corset. This is an old school style. However, sometimes we need to use it for certain amputees. So it's indicated for people with unstable knee joints, when other suspension mechanisms are insufficient, heavy-duty amputees, when there is a necessity to offload the residual limb. Is contraindicated for very short limbs with minimal inherent stability. Components. I will focus on the prosthetic feet. However, the components are not limited to the foot. They can be the pump for elevated vacuum suspension mechanism, or it can be a slider to insert and outside the foot. We classify the feet based on the functional level, and I will talk about it in the next slide. However, we have different types. One of them is the sash foot, is used for K1 or above. This is the basic prosthetic foot and made of wood. It promotes knee stability. Plus it has rigid midfoot, which provides stability in mid-stance. The single axis also used for individuals with K1 level or above. It stimulates dorsiflexion and planiflexion through adjustable bumper. Multi-axis is used for K2 or above. It has adjustable bumper that allows a slight configuration to irregular or uneven surfaces. So it will allow inversion and eversion of the foot, so the patients can use it when they are walking on different terrains. Dynamic response foot is used for K3 or above. It increases energy return because it's made of carbon fiber, plus it decreases energy expenditure. Hydraulic foot is used for K3 or above. Some K2, I've used it multiple times for K2 patients, and they like it because they feel it's almost like anatomical foot. It has the dorsiflexion and a planiflexion moments. So it added toe clearance in a swing phase. It moves more similar to an anatomical human foot. And it reduces compensatory motions at the knee and hip. Microprocessor foot, this one is used for K3 or above. It's used for active, that has active response to environmental changes. Sport feet, the most popular one is the blade or running foot. Is used for K4 and is customized based on the anticipated activity. Functional level, you've heard this term multiple times today. So we have 5 functional levels, 0, 1, 2, 3, 4. K0, when there is no ability or potential to ambulate or transfer. So the patient will not have the ability or potential to transfer or ambulate. K1, when the patient has the ability or potential to use the prosthesis for transfers or ambulation in level surfaces at fixed cadence. K2 has the ability or potential for ambulation with and level environmental barriers, so they will be able to climb stairs up and down. K3, they have the ability or potential for ambulation with variable cadence. K4 is athletes or active individuals, so they will exceed basic ambulation skills. Outcome measures, you've heard it also multiple times, but we are repeating this because it's the evidence-based practice. It can be done by prosthetists, physical therapists, but we as healthcare providers, we need to do it in order to determine the functional level, plus in order to see how our patients are progressing. So I'm just gonna throw, again, I mentioned them briefly. We have 10-meter tests, amputee mobility protector. We can do it without a prosthesis or with a prosthesis. Socket comfort level is the simplest and easiest one. We can just ask the patient, how would you rate the comfort level of your prosthesis on a scale 1 to 10, where the 10 is the highest? Timed up and go test is used for K2 only. 4 square test used for K3 and 4 only, and 2-minute walk. After formulating the treatment plan, determining the functional level, that doesn't mean the journey is over. Patients need to come to us back to follow up because they will experience volume fluctuation. So we will need to explain to them how to use prosthetic socks to manage that volume fluctuation. We need to do gait troubleshooting. Always reassess the gait, identify the deviation, determine the possible cause. Is it the patient or the prosthesis? Then decide the correction of procedure. Re-evaluate the functional level. If needed, replace the foot. And how to evaluate that is through the outcome measure, okay? Finally, my take-home message to everyone here is the following. Amputation shouldn't be looked as a failure. It should be viewed as the first positive step of physical rehabilitation that will provide the patient with the functional residual limb that can be fitted well with the prosthesis and improve patients' quality of life. Next step in case A, I would like us to use more of the modern or advanced technology and not rely on the basic one. So I would love us to see flexible inner liner, elevated vacuum suspension, running feet. Also, peer support groups. We as prosthetists, we can create those groups just to gather our patients together because they are the only ones who know what they are going through, so they can gather together and go through explain what they did in order to go through this experience. Also, activity is one of the visions in case A, so I'd love us to see more of Endeavor Games or start Paralympic, prepare our patients to participate in Paralympic Games. That's it. Thank you for listening, and let me know if you have any questions.
Thank you very much for the informative information that Zaina provided us today. And for now, I would like to introduce our next presenter, who is going to discuss about the addressing main gait deviation in lower limb prosthetic users. He is a senior prosthetist and orthotist. Please have a round of applause to our CPO, Abdessalam Al-Amri, to the stage.
Hi everyone. Today my lecture is going about addressing the main gait deviations in lower limb prosthetic users, the impact of prosthetic designs, components, and alignments on gait efficiency. So this is our objective for today. We want to evaluate the role of prosthetic components and alignment improving the gait stability and efficiency, and we want to examine the impact of prosthetic socket design on gait efficiency and user comfort, and we want to identify and analyze the common gait deviations in lower limb prosthetic user, and we want to provide insight how to use or how to optimize the prosthetic fitting and gait deviation for the patient. Before we start anything, we want to understand what is prosthetics. The prosthetic or the prosthesis is an artificial device that substitutes a missing part of the body. And simply, we have above knee prosthesis and below knee prosthesis. The above knee prosthesis, it have socket, as we see here. This is the first part of the prosthesis, and this is contact the residual limb with the other components of the prosthesis. And we have something inside that suspend the prosthesis, how the patient can hold the prosthesis. There is a liner that hold the prosthesis while the patient walk. And we have the knee, it's mimicking the natural knee of the normal people, and we have the pylon that act as a leg. And the last thing, we have the foot. The main difference between the above knee prosthesis and lower knee prosthesis is the knee and the socket design. It's different. Here we have two common designs prosthesis for the patient. We have patellar tendon bearing prosthesis, socket design, and we have total surface bearing. So in brief, what's the main difference between the total bearing socket design and the total surface bearing design? The patellar tendon bearing, the patient hold most of the weight up. So the patient have sensitive and residual limb. We cannot go with the total surface bearing because the patient may feel some pain at the end of the residual limb. The total surface bearing, we go and use this for patient if the patient have really good skin and it's rounded shape, they don't have any bony prominence, we go with the second style. Moving to the above knee prosthesis, we have two common prostheses. We have the ischial containment socket, and it's the most used among amputees, and we have subischial. So what's the main difference between the ischial containment socket and the subischial containment socket? So for this prosthesis, if you see here, it's ischial containment socket. So the ischial bone will be here, the patient will sit here, and it's contain the ischial. For this, it gives the patient a better control in the frontal plane while the patient walk. If the patient doesn't have a good control, it feels like the hip is dropping. So we contain the ischial here while they walk, so the patient feel they are stable while they advance their limb. The another socket design is the subischial, and this one is below the ischial, and it doesn't contain any bone. And why we use this one? Why we just go with the ischial containment and that's it? The subischial, some patients, they prefer it because they have more range of motion while they walk. They feel they are more comfortable while they are walking. And here is the study. They bring 3 patients with ischial containment socket, and they start fabricating subischial containment socket for them, and they saw the main difference between the ischial containment and the subischial containment. And as we see here, the result for those patients, they have more range of motion while they walk with the subischial containment socket. And they got their feedback, which one they prefer, and most of them, they prefer the subischial containment socket because they can do squatting, they can do cycling, they do most of the activities. One of them, he just preferred the ischial containment socket, and that's because they feel they have more control over the subischial containment socket. Moving to the suspension system,
we have 3 main suspension systems. I know I just give you the information again for Zainab. But anyway, we have 3 main suspension systems: pin lock system, and suction system, and vacuum assisted suspension. And I think she explained this enough. We will go over the knees. We have many different knees for patients. We have the single axis knee, and it comes as locked knee and free movement. And this one, we use it for patients who doesn't have a good muscle strength while they walk. We cannot give patient polycentric or, for example, celiac while they have really weak muscles, because this is not useful for them. And we have the polycentric knee, and the good thing about this polycentric knee, it clears the foot during swing phase. So the patient have better swing phase when they use this one. And we have the hydraulic knee. This hydraulic knee, it comes as oil. It gives resistance during stance phase, and it gives pendulum effect during swing phase. It helps in reducing the energy expenditure for patients. As you see here, this one is a hydraulic knee, so it's a good one for patients. They feel they are comfortable with it. It also gives a good resistance while they walk. We have the pneumatic knee, and the main difference between the pneumatic knee and hydraulic knee is the pneumatic is air inside, air resistance comparing to the hydraulic. The last one is the microprocessor knee, and it's the most advanced knee in the market. It's good for patients. It's mimicking the locomotion, the normal locomotion for patients. We have here, I just want to give you an idea how we choose the right knee for the right patient. We have 5 K levels. For K1, single axis, we cannot give the patient, as what I said, a celiac knee because it's not useful for them, and vice versa, we cannot give the K4 single axis because we are limiting their functionality during it. Applying the same on the feet to patients with K4, they are really active. We cannot give them such foot because we are limiting their functionality. We have to go with something is suitable for them. For K4, we can go with energy storing feet, with the displayed feet, and for K1, we have to go with the such foot because it's safe. Patient can walk with that, and we reduce the risk of falling for those amputees. Alignment in prosthesis. Alignment is a crucial thing for us as CBOs because with a good alignment, we make the patient walk really good. We are making the patient feel safe and feel secure in the prosthesis. We have a very detailed alignment. We concern about the patient. Like here in the static alignment for above prosthesis, we cannot make the socket an extension because here, if you see, if we keep it in extension, we increase the lordosis in the patient and we may cause pain for the patient. We have to mimic the natural flexion for them so they feel they are more comfortable while they walk. The socket adduction, it has to be aligned naturally with the femur, and for the knee positioning, here we have to make sure the knee position in the right place so the patient feels safe when they walk and when they do their ADL's activity. The foot position has to be in out a little bit, as you see, to promote the natural gait pattern. So from 3 to 5 degrees out to mimic also the natural foot or the intact limb. Moving to the below knee prosthesis, the socket has to be from 5 to 10 degrees flexion. The patient will feel more comfortable with this alignment, and the socket has to be in adduction, and we have to make sure the foot is positioned in the right manner and toe out from 3 to 5, 2. And we have to concern that we have to do the alignment with the shoes, because when we do the alignment without the shoes and the patient later just wear the shoes, the alignment will be changed, and that may cause some issues for us. When we do the static alignment for patients and we move and we let the patient walk, we start see we see some gait deviations for the patients. So here we move to do some dynamic alignments. We see the patients, how they walk, and then we adjust the socket, we adjust the knee, we adjust the feet. All these are important. As you see here, the goal is to optimizing the gait efficiency, comfort, and stability during movement for both above knee and below knee prosthetic users. Gait cycle. So it's typical and efficient walking pattern characterized by coordinated rhythm movement of lower limb. It enables forward progression while maintaining stability and energy efficiency. So 60% in stance phase and 40% in a swing phase. And here talking about the ground reaction force. Ground reaction force is a main concern for us because we can see where we put our components. We put it in a flexion moment or extension moment, and we just have to analyze the patient, how they walk, and then we can adjust the prosthetic. So what's the ground reaction force? It's the force exerted by the ground on the body in contact with it. The force occurs in response to the body weight and movement, and it's equal in magnitude but opposite in direction. So it indicates the weight distribution and load on the prosthesis. It guides us in alignment. It provides insight how to choose the components, and for also gait asymmetry, energy efficiency, shock absorption, and stability. Definition of gait efficiency. Gait efficiency refers to energy expenditure and biomechanics involved in walking, and efficient gait uses minimal energy and maintains balance, stability, and fluidity in movement. So energy conservation, reduce physical strain, improve mobility and independence, and prosthetic longevity. So how the prosthetic design impact the gait efficiency? For patellar tendon, PTB, and total surface bearing, design emphasizes the knee control, providing better alignment and comfort. And for AK, ischial containment socket, as what I said, we contain the ischial while the patient walk, so that will conserve a lot of energy and make the patient walk in a better way. Moving to the gait deviations and complete what Abdullah have started from the prosthetic side. We have a prosthetic side and we have physical side. So Abdullah talked about the physical side and how the gait deviations may occur because the muscles weakness or bad habit of walk. And here I will mention how the gait deviations may be because the prosthetic not in a good design or not in a good alignment. So we will start with the abducted prosthetic gait. So the prosthetic leg positioned wider than necessary, causing exaggerated separation of the legs while walking. So the patient will walk in abducted gait, and that because the alignment may be bad, and we have to adjust the alignment of the prosthesis, or maybe the medial brim of the prosthesis is really high from here, so we have to decrease the medial brim so the patient will feel more comfortable while they walk. And maybe because there is a gap on the lateral side of the prosthesis, And here we have to contour it more to make the patient more stable while they walk. Lateral trunk bending is the patient will bend towards the prosthetic aspect, and that's because maybe the prosthesis is short, so we have to adjust the height, and we have to work on the alignment too, and use properly contoured lateral wall. Circumduction gait is one of the most common gait deviation, and that's maybe because the prosthesis is long, so we have to shorten the prosthesis so the patient can clear the prosthesis while they walk. And maybe the friction of the knee is high, so the patient want to flex the knee, but they cannot because they have a high resistance. So we have to decrease the resistance of the knee so the patient can advance their prosthesis while they walk. And we have to check the proper alignment for the prosthesis. And here we have for below knee, the knee fully extended at the heel strike. And the normal gait, the patient have to have at least a slight flexion at the initial contact loading response. And that's because there is issues with choosing the components, the stiffness of the heel. So we have to adjust first the alignment. We have to check what foot did we use for the patient. We have a video here. I'm not sure if it will be play or... Can you play this video, please? Okay, no problem. So the idea here is the patient doesn't have enough flexion at the initial stance phase. As you see here, the patient walk, but they don't have enough flexion. And moving to the last gait deviation, vaulting gait, the patient will plantar flex the intact limb, trying to advance the prosthetic limb. And that's maybe because the patient have long prosthetic device, or maybe the patient have a bad habit when they walk. Thank you so much. الله يعافيك. الله يعافيك.
Thank you very much for Abdessalam Al-Amri for sharing his knowledge with us. Also, the presentation was very knowledgeable and not only knowledgeable, but also was engageable. And I'm sure that our audience have now learned more about the prosthetics component. And for now, we will stop for prayer. We will resume after 10 minutes for our final speaker, Dr. Mohammed Sil Arabi.
Okay.
Apologies. We will let our speaker, Mohammed Sil Arabi, start his presentation. Please welcome Dr. Mohammed Sil Arabi to the stage.
Thank you. Good afternoon, everybody. I will talk about phantom limb pain and phantom sensation. This is a phenomenon which is known since a long time, but unfortunately, it's until now, the pathophysiology is not clear. We cannot explain what is really going on for the phantom limb. The definition of the phantom limb is pain that is localized in the region of the removed body part. The part of the limb is amputated, but the patient feels the pain in his limb while the limb is absent. Yeah, it is really difficult, and the pain is sometimes very severe. And the phantom sensation is just the patient feels his limb, but there is no pain. He can feel the toes or the fingers moving. He can feel a pruritus. He can feel something touch, but it's not painful. But the most important is the phantom limb pain. Phantom limb pain is really difficult to manage. Second thing, the patient generally is not informed by the surgeon about this phantom pain. And really, it's a big problem because generally, when we receive the patient with amputation, he will never speak spontaneously about his phantom limb. If we don't ask him, and we ask him and reassure him that it is something normal, because most of the times patients feel that they are crazy. That's why they don't talk about their phantom pain, the phantom limb, because how can he imagines that people will take him as someone crazy because he's talking about something which is not palpable, which is not existing, and he complains of pain in the limb which is no more pertaining to his body. That's why we have to inform the patient that it is important to inform him, because he will be able to express what he is feeling. Otherwise, he is scared by the consideration of the people surrounding him. People will consider him as crazy. Why? You are complaining of pain in your leg, and your leg is no more in your body or in the upper limb. This is a big problem. We have to explain to the patient that there is an image of his limb in his cortex, and there are some reactions. We cannot explain in details what is going on, but at least we can give him an explanation that there is an image of his limb in his brain, and the brain is always feeling the sensations which are normally existing before the amputation. This is very important. As I said, it was Ambroise Paré, who is a French surgeon in the 16th century, who was the first one to describe phantom sensation. But unfortunately, until now, the pathophysiology is unclear. There are many theories regarding the phantom limb sensation and phantom limb pain. During the amputation, there is a significant, we call it peripheral nerve changes, there are peripheral nerve changes and other theories. Significant amount of trauma that occurs in the nerves and surrounding tissues. This damage disrupts the normal afferent and efferent signals involved with the missing limb. You know, the afferent is the message and the signal which is going from the peripheral to the brain, and the efferent is the signal coming from the brain to the periphery. The proximal portions of the severed nerves start to sprout neuromas, and the nerves become hyper-excitable due to an increase in sodium channels and resulting in spontaneous discharges. This is really difficult to understand because it's really very small. There are sprout neuromas, but we are not 100% sure that there are sprout neuromas which become very hyper-excitable, and it increases the sodium channels, and there are spontaneous discharges. There are the other theories, spinal cord changes. In the spinal cord, the process called central sensitization occurs. Central sensitization is a process where neural activity increases, the neural receptive field expands, and the nerves become hypersensitive. This is due to an increase of the N-methyl D-aspartate activity in the dorsal horn of the spinal cord, making them more susceptible to activation by substance P, tachykinins and neurokinins, followed by an upregulation of the receptors in that area. For everybody, it seems that it is Chinese, difficult to understand. Yes, but it means that there is this N-methyl D-aspartate, which is really important in the horn of the spinal cord. It makes sensitivity of the nerves, and they react to get upregulations of the receptors in the area. Still difficult to understand, it's nearly Chinese, but the combination of increased activity to nociceptive signals as well as a decrease in the inhibitory activity from the supraspinal centers is thought to be one of the major contributors to phantom limb pain. There are also brain changes. The cortical reorganization is a commonly cited factor in phantom pain. There is also the theory of proprioceptive memory. Amputees continue to have proprioception of the missing limb. When it happens, the onset is mostly immediate after the amputation. Some at a few weeks, rarely a few months later. But there is an American study which found 3 to 4% of individuals with amputation onset of phantom limb pain occurred more than 1 year after amputation. 1/3 of patients experience maximal symptoms immediately post-op and generally resolved by 100 days. 50% experience pain that slowly peaks and is improved within 100 days. A quarter of patients experience slower rise towards maximal pain. This is an American study. The symptoms that we are facing with phantom limb pain are really
very important to know because they are very disturbing to the patient. The phantom limb causes painful sensations as itching, burning, itching, numbness, pinching, tingling, stabbing, temperature change, throbbing, twisting. You have some examples here in this caricature, but it is really disturbing the patient. The patient might feel like his missing limb is still attached in an unusual position, sometimes in a position which is abnormal, moving around or shrinking. It's really a big sensation for the patient. Post-amputation pain is one of the most common and challenging pain conditions to treat and includes residual pain and phantom limb pain. Residual limb pain is present at the amputation site. This is in the stump. It could be due to poor wound healing or poor prosthetic fitting or neuropathic pain. We have a protocol to treat this pain. But phantom limb pain is experienced distal to the amputation. It means below the stump. And may be caused by maladaptive supraspinal reorganization. This is the theory of the brain reorganization. As you know, there is a representation of all parts of the body in the cortex. We call this neuromatrix or somatotopy. Somatotopy, it means every part of the body is represented. I will show you one picture. This is the picture. You have in the brain, you see the lower limb is, I don't know, it's not working. No, sorry. Yeah, the lower limb. Hold, okay. Yeah, see the lower limb? The whole lower limb is here. The hand, see the hand alone represents mainly half of the lower limb. It is more represented in the brain. That's why we have mostly more phantom limb pain in the upper limb because of this somatotopic representation in the cortex. What are the risk factors for phantom limb pain? Anyone who has an amputation can develop phantom limb pain. It's more common in the upper extremity, as I said, but it can affect any part of the body. In the patient if the patient wears regularly his prosthesis, generally when he removes the prosthesis, he will feel more pain because the contact with the prosthesis will reduce this phantom limb pain. The complications of the phantom limb pain, living with the pain is not easy, as everybody can imagine. Phantom limb pain can have a serious impact on the mental health and in some cases leads to anxiety and or depression. The pain can interfere with all the activities of daily living and mainly there is insomnia due to the pain. He cannot sleep, he cannot have a rest, and even his activities are perturbed because of the pain, the either leisure activities or in his work. Treatment for post-amputation pain should be multimodal, multidisciplinary, including pharmacologic agents, rehabilitation, psychosocial support, and integrative therapies. As it was said by all the speakers, the multidisciplinary approach is very important. As everybody understands, there are many problems related to the phantom limb pain. There is an impact, a psychological impact. It means the psychologist has to intervene. The physiotherapist has an important role because he can use some modalities which can decrease the pain. And we will see the main treatment is not only medications. Medications can help, but generally they are not very efficient in the phantom limb pain. That's why we will talk about mirror therapy, which is really a method which can really help a lot the patient. I have an experience with that. I will talk about it. Yeah, the phantom is, I need prescription for phantom pain. Yeah, the management of this phantom limb pain, we have medications, mirror therapy, transcutaneous electrical nerve stimulation, spinal cord stimulation, neurostimulation, stump revision surgery. Sometimes all the conservative treatments will not give results. We have to go to the surgeon again. There are some complementary therapies like acupuncture, biofeedback, cognitive behavioral therapy, massage of the amputation area, relaxation techniques can be in the weapons which can help the physician and the patient. Medications. We have different types of medications. Non-steroidal anti-inflammatory drugs like Voltaren, Brufen, Celecoxib, whatever. You have to use it, but generally unsuccessful. You can get a little decrease of the pain, but it's always disturbing the patient. Pain relievers like paracetamol, like opioids. Opioids can help in some cases. We have to go to opioids because no other medication can be efficient. Antidepressants like escitalopram, fluoxetine, this can give some results, but not really total satisfaction to the patient. Anti-seizure medication, gabapentin, pregabalin, we know that they have a good effect in the neuropathic pain, but in the phantom limb pain, the effect is limited. Beta blockers also can have an effect, like propranolol, calcium channel blockers, like nifedipine, but we are not satisfied by the results, but use them because sometimes it helps a little bit. Mirror therapy is really now important in the management of the phantom limb pain. It was introduced to the therapy by Ramachandran, one Indian guy, in 1996 for the phantom limb pain. It is really, it's a technique that uses a mirror. It's sagittal, in the sagittal plan, so that the patient, when he looks to the mirror, he will see his unaffected limb. Unaffected limb, it means he has his, for example, the left side is unaffected, the right side is amputated. The mirror is between the two, and he will see the sound leg in the mirror. The physiotherapist will give him exercises. When he moves his unaffected leg, he will feel that the affected leg is moving. The amputated one is moving as it is normal. During this therapy, we said the mirror reflection makes it like the missing limb is still there. A therapist will guide movement exercises with the unaffected limb, and the patient will watch the movements in the mirror. This tricks the brain into thinking there are two healthy limbs. Yeah, gradually, the patient will feel that his leg is moving normally, like the unaffected one. This is the mirror, and the patient is looking to the mirror, and he's seeing his sound leg. And when he moves, it will trick the brain, and there is a good result sometimes. This, we experienced this method in Sultan bin Abdulaziz Mtarin City. We had the patients, we give them a daily session for 30 minutes. After 4 weeks, there was a significant improvement in the phantom limb pain. Really, it's fantastic. We continued during 6 months. During 6 months, we had very good results, and the patients were very satisfied by mirror therapy. It's a method which is not invasive, which is very simple to implement, and really the results are satisfactory. That's why mirror therapy is one of the best methods to treat the phantom limb pain. You have massage. Massage is important. This is a video, but I think it's, I don't know if we can watch it. Just manipulation of the scar of the patient. There is a method to go deeply, and really it helps the patient. And the recommendation when we have patient with phantom limb pain, we recommend to the patient to take his stump with the 2 hands and to manipulate the stump during few seconds. After a few seconds, he will feel better. This is one of the methods. There is another one, another video. Sorry. No. Where I'm going. Which is the button? The first one to come back? Sorry. Yeah, it's okay. Yeah, this one is another video to show how, sorry. Yeah, it's a video also how to manipulate the stump There is a sound. You can play the video. No, it's not playing. It's okay. It's a manipulation of the stamp. She shows how to manipulate, how to make some manipulation of the stamp one to decrease either sensitivity of the stamp when there is a neuroma, when there is hypersensitivity. This can help the patient, and we show him and we teach him how to do it alone. This will help the patient to decrease his phantom limb pain. Okay. There are some problems which can increase the occurrence of the phantom limb pain: fatigue, stress, anxiety, depression will increase the possibility for the patient to have the phantom limb pain. Infection, blood flow issues, pressure or swelling on the stump. In summary, following amputation, most patients still report feeling the missing limb and often describe it painful. Sorry. It impacts negatively the quality of life. The researchers are still facing difficulties, no successful results until now. The better understanding of pathophysiology and etiology will help to find new modalities to alleviate the suffering it causes. Thank you. This guy is telling his doctor, I feel vibration in my pocket, doctor. He said, you have developed phantom phone syndrome. Thank you very much. حطه هنا. Okay. Any questions?
Thank you very much for Dr. Mohammed Al-Arabi for sharing his knowledge, and I would like to introduce Dr. Mohammed Al-Arabi, because we forgot to announce the Mohammed Al-Arabi probably before his presentation. Dr. Mohammed Al-Arabi is a consultant physical medicine and rehabilitation at Prince Sultan Rehabilitation Complex, Ífáء. Please, I would like to ask Abdussalam Al-Amri to come again to the stage, and we will start our discussion panel.
تفضل.
أهلا دكتور.
أهلا بك.
First of all, thank you very much for your valuable information that you've provided us today. And first of all, I would like to ask some information about your presentation that you presented. First of all, I would like to start with Mr. Abdussalam Al-Amri. You are actually the leader of prosthetics department in the health, the Ministry of Health, and mashallah, I would like to ask you about the information you shared with us today. You mentioned the prescriptions for prosthetics component as well as alignment for the amputees. When working with the quadruple amputees, how do you approach the decision-making process in terms of the type of the prosthesis and the potential risk for those patients, especially that they have amputee on the upper limb and the lower limb as well, and how that will change the prescription from the alignment perspective and as well as the materials that you will use for these patients?
Okay. Regarding the quadrilateral amputees, it's really challenging to choose the right prosthetic for them. So before we choose or we make decision, it's a multidisciplinary team. So the decision making based on the physiatrist, on the physical therapist, on the orthotist and prosthetist, the team at all. So we have to measure this from many perspectives. We have to see first if the patient is capable of taking this prosthesis and wearing this prosthesis. Also, we have to check the functionality of the patient, the desire of the patient, all the outcome measures. We have to check all of this. Besides this, we have to ask the patient about their environment. Is it suitable for them? Is it safety to use this prosthesis? And based on all of these factors, we choose the right prosthesis for this patient. We have to consider also the alignment. We have to make sure that the patient will not fall, because the risk of fall is really high for those patients. We have also to consider the donning and doffing of the prosthesis, because they have bilateral above upper limb amputation, and they have below knee bilateral amputation. So considering many things, it's really important. For the alignment for the below knee or the lower limb amputation, we have to consider that we have to put the alignment in extension moment, and this is really important for the safety of the patient. So it's many factors we have to consider based on the patient functionality, their desire.
Thank you very much. Now, I would like to ask Dr. Mohammed Silarabi a question regarding the information you mentioned that there is a medication as well as mirror therapy for a phantom limb. I would like to ask, why would you consider using a medication instead of mirror therapy and vice versa?
Yeah, it's the mirror therapy is not used since a long time. The first one to introduce the mirror therapy is the Indian guy Ramachandran in 1996. It means it's not so old, okay. And the experiment that he had was very limited at that time, but gradually it was used, and they found efficiency of this method. Sorry. They use mirror therapy now even in the stroke for the sorry. Thank you. Yes, this method is used even in the stroke, because the shoulder pain is really decreasing with mirror therapy. We had also this experience in Sultan bin Abdulaziz Military City. We had a number of patients who were complaining of severe pain in the shoulder, and we started mirror therapy with these people. we got very good results, better than medications. We were putting these patients on medications. There was some improvement, but mirror therapy, we got improvement quicker, and the patient are more satisfied with mirror therapy. And now, sure that medications, we have to use also sometimes medications, because despite the mirror therapy, there are some residual pain which cannot disappear without intervention of medications. It means we can use both mirror therapy and medications. But mirror therapy is really promising method of treatment in the phantom limb pain.
Thank you very much. Now we would like to ask our audience if they have any questions for our presenters. Please.
يعطيكم العافية جميعا. موضوع very interesting من الأخصائي أول عبد السلام وأيضا من الدكتور محمد. I want to ask you two questions, actually, Dr. Muhammad, regarding to phantom pain. You mentioned that we need to inform the patient about phantom pain. In which stage we need to inform the patient about the pain? Do you think it's good to inform the patient before the amputation or after the amputation?
Yeah, we have to inform the patient before the amputation, because we know that 80%, nearly, the average is 80% of the patients are having phantom limb after amputation. It means it could be phantom limb sensation, it could be phantom limb pain. We cannot say automatically he will have phantom limb pain. But we have to inform him that there is this possibility to have phantom limb pain. Like this, the patient will not be shameful in front of others, because he cannot say he is suffering, but he cannot say it to others, because others will consider him as crazy. How you complain of something which is not existing?
Exactly. I see that in the
and this is important. Yeah, we have to inform the patient before the amputation that there is this phenomenon. This phenomenon can exist within 80% of the patients who have an amputation. It means it's important to inform them before. Like this, they can even react and to confide this to his physician or to his therapist. It is very important. Now, when we have an assessment of the patient with an amputation, we have to ask him if he has this phantom sensation or phantom limb pain, and you have to explain before his answer that it's something natural that we can find in most of the amputated patients.
Thank you so much. My next question is about mirror therapy. What is your answer to those who proclaim that using mirror therapy can retrieve the grave reaction to the patient? They feel sad.
Sorry, I didn't hear your question. So excuse me. Can you repeat it?
Yes, of course. When application the mirror therapy,
yes,
some patient cries because it retrieves the grave reaction when they lose their limb. What do you think about that? Do you think it might impact the progress in their rehabilitation? Though the mirror therapy help in reducing pain, but these grave reactions might cause some psychological consequences?
Yeah, but we have to educate the patient before starting the mirror therapy, to educate him that there are signs which are not agreeable to him in the beginning. You know, sometimes even he can have nausea. He can have even vomiting.
Exactly.
Yeah, we have to inform him. When we inform him, he's okay, he's aware about what is going on. He will accept and he will see the results after that. But if you don't inform him, yes, sure, the patient is discouraged and he will say, please, thank you, we stop here. Okay.
Thank you so much, Doctor.
You're welcome.
I just want to share my experience about reading about phantom pain. It was my dissertation topic in my master's degree.
Yes.
Actually, the experience of phantom pain itself, it's varying from person to person. And for traumatic reason, they feel even severe pain than with vascular-related amputations. And from the patient experience, most of patients use several techniques to control the pain. So the patient needs to know how to control this pain and how to live with this pain. And with phantom sensation, most of amputees, in the study I did, once they get the prosthesis, they felt their prosthesis as part of their body because of phantom sensation. So when hits any like wall while they're walking, they feel real pain, that like the pain is existed. So it's good thing.
Sure.
Yeah. Thank you so much for.
You're welcome.
Any other questions? Okay. I have a question for I have a question actually for Mr. Abdessalam. How would you handle a situation where the cost of the prosthesis is a barrier to obtaining a device that would be ideal for the patient, especially that we follow a K level to prescribe any prosthetic device? How would you manage this ethical dilemma?
Okay, regarding the first question is the cost. It's really a crucial thing that we have to consider the cost as the main thing for the patients, for choosing the components. Some of the needs, for example, the mechanism of their working close, but there is a high difference in the price. So considering the cost is really important. We can give the patients the most advanced prosthesis, and they cannot afford it. At the same time, we can give them a standard prosthesis, and it's doing the same or close of the functional seek for the patient. So it's really considerable. Regarding the second question, what is?
If I asked that we have to follow the K level in terms of the prescription, but how would you manage the ethical of giving a prescription that is kind of like not the function of the device, not the thing that you want for this patient?
Sure. We contribute many factors. It's not only the K levels. We contribute the outcome measures. We contribute the SOAP notes, documentations. I always focus on the documentations for the patients, because it's one of the most important things that it gives us proofs that the patient deserves this kind of prosthesis or this kind of device. From my clinical experience, we're doing full documentation for the patient, starting from the SOAP note, the justifications. We give pictures for the patient. We also take the L codes, and this is a thing in the insurance system that you have to put everything you have put for the patient. It's kind of justification. It's very detailed things, like even the screws that you use for the prosthesis, you have to document this. So it's kind of enough justifications that the patient deserves this kind of prosthesis.
Thank you very much. And any questions from the audience, please?
Yes.
The mic to...
From your experience, is there any study comparing يعني ايش البرسنتج الأعلى regarding gait deviation? Is it physical causes, is it medical causes, or prosthetic reasons?
From my clinical experience, it's more from prosthetic cause, and I believe we need more experience in how to do the alignment and understanding how we align the prosthesis within the body is really important, and how we fabricate the prosthesis. It's many factors. So I believe it's the prosthetic cause more than physical cause.
Thank you.
And any other questions from the audience? Okay. I would like to ask another question for Dr. Mohammed Silarabi. You mentioned the medication for the phantom pain. What is the best treatment for phantom limb in dialysis patients, especially we have to use medication, and this medication you mentioned have a side effect?
Yes.
Yes.
Yeah, we start by the simple ones. We start by paracetamol, for example. Simple but dangerous for the liver if you take the huge doses, and during a long time, you can have a problem, hepatic problem. But the simplest one is to take, for example, 1 gram 2 to 3 times daily. It will be normally efficient. But if it doesn't give you any result, you have to go to higher. You go to non-steroidal anti-inflammatory drugs first. You start with that. For example, you take celecoxib 200 milligram 3 times daily. If there is no result after a few days, you have to go to higher. Higher, it means opioids. Tramadol, you start by tramadol with a small dose and increase it until you reach the efficient dose. Because with opioids, no possibility for all the pain can be managed by opioids. This is the highest one. But regarding the antidepressants or anti-epileptics, the effect is very limited.
Thank you very much for your time and effort. And before we wrap up, I would like to offer a final word of thanks for the panelists and also the audience that they came in today, and for the first day of the scientific forum for recovery and rehabilitation in person with limb amputation. We appreciate the time and effort you have put in today's sessions, and special thanks to Prince Sultan Rehabilitation Complex, Ífáء, and the Dmam Medical Complex. That brings us to the end of our discussion, and I would like to thank you once again, and I hope we see you tomorrow, inshallah, for the second day.
Thank you.